Commerce and Labor to order. Clerk, if you would open the roll.
You have a quorum, Mr. Chair.
All right, thank you. We have a busy docket, goes without saying. We will try to move as expeditiously through, but there are a number of key issues in here. So we're going to try to deal with them in a manner. We do have bills, several patrons put in bills on a similar subject. So we will try to group those as best we can. Starting, who patrons do we have? Senator Servo.
Thank you, Mr. Chairman. I have a substitute for 1759.
Is there a motion on the substitute? Been moved and seconded the substitute be agreed to. All those in favor say aye. By a vote of 0-0, and there's no nays, the substitute's before us. Senator Servo.
Thank you, Mr. Chairman. 1759, as amended as substitute, is a pilot project for electrical utility undergrounding in transit-oriented development. So the committee knows there's a project that's going forward in my district. The Northern Virginia Transportation Authority and VDOT have allocated so far about $500 million towards construction of it. Right now, the utilities are scheduled to be above ground, and the utilities need to go below ground because it's transit-oriented development, and we don't really do above-ground utilities with transit-oriented development. Basically, the pilot calls for the lines to go under, assuming CTB agrees to it. The costs would be spread across all ratepayers, and I can answer any questions if the committee has. But the problem is VDOT does not pay to underground utilities because it typically costs about 4 times more. And if we underground utilities on every transit project, it would throw the transit projects out of smart scale in any kind of meaningful way. And that's the bill. I'm happy to answer any questions anybody has.
Are there questions for the patron? Okay, are there those who wish to speak in favor of the bill?
Mr. Chairman, John Russ for Dominion. I appreciate the patron working with us on this bill. There are issues in these types of developments in terms of coordinating the activities of the locality, the utility, and CTB that this would assist us in doing. It also permits us an opportunity to look at how this can be done in the future, and it allows us to work out the coordination between the three.
Jack, let me ask you a couple
Yes, sir.
questions here. In other words, what we're looking at here, if I'm misunderstood, is that Dominion will pick up the costs of relocating these as opposed to what would normally be associated with a transportation project, which is what the cost of the transportation project would normally be relocating and realigning these.
Mr. Chairman, the answer is that there will be a variety of shared costs on this. The CTB will have a number that they're willing to put forward for the relocation. The locality will have a share. This would permit any share that's not picked up by those two to be picked up in the rate base.
And here's my concern. I mean, we added, as you're aware, coal ash. We've added so many expenses on here. And what we're asking to do is we're starting down a road that I'm not aware of we've ever gone down, where the utility starts picking up the cost for starting to relocate some of these utilities on a new construction road or bridge project. And ratepayers and all over the district, including mine, because there's a problem in Fairfax, their rates are going to go up because we're going to use their money to locate something that would otherwise be associated with the cost of that road project. Can you tell me I'm wrong there?
Mr. Chairman, that's one of the reasons that we had concern with the bill as originally introduced. This is a pilot program. We limited to no more than 2 projects, would give us an opportunity to look at it. There will be a ratepayer impact, but we think it'll be minimal.
Yeah, I realize pilot programs. I've been around there a couple of
Yes,
years,
sir.
as you're
Yes, sir, I
aware,
know
Mr. Rust, and pilot programs have a way of growing and growing and growing. We've done a number of things, and I think we all take pride in the fact that we have extremely competitive electric rates in Virginia, and this very much concerns me that we're headed down this road. But are there others that wish to speak in favor of the bill?
Good morning, Mr. Chairman, many members of the committee. My name is Robert Hofrichter. I'm with the Virginia Department of Transportation. We're not strictly speaking for the bill or against. I just would like to point out that We do have some technical issues with the amendment as proposed, and we're willing to work with the sponsor to fix those.
If you still have a bill. Okay, thank you. Are there any others? Are there others that wish to speak against the bill?
Got it.
Okay, Senator Servo.
Mr. Chairman, I have to say a couple things in response to your comments. First of all, this would not, there are multiple utilities on this project. There's electricity, there's telecom, and there's cable. This only deals with the electric, and VDOT would still throw in the cost towards what they would normally pay for an overhead relocation on the balance. The balance of the cost, if the other utilities were to go under, would be paid for by the locality. You're going to see more and more of these projects coming as we invest more and more in transit and more in transit-oriented development, which from my perspective is a lot smarter than building roads out into the countryside and continue to pave over countryside, where everybody ends up paying for these transportation projects. This is a more efficient way to build. And when you build transit-oriented development, you don't string wires all over the place. You put them under, and that's the proper way to do infrastructure, which is why it's a community expense. And so this is why we need to start figuring this out and figuring it out sooner rather than later before we have 5 of these projects that we're trying to figure out instead of just one. And that's why it's a good pilot, and I think the committee ought to support it.
Okay, thank you, Senator Servo, but I think you captured my concern right out of the chute when you said it's a pilot program and you're telling me we're going to see more and more of these programs. Once again, we're shifting costs from one budget and putting it on the electric companies. And one of these days, all of us are going to be sitting there going, how come our electric rates are so high? And everybody's going to blame the utility when we keep piling on these programs. But the committee operates by motion. It's been moved and seconded that the bill be reported. Oh, and re-referred to the Committee on Finance. Clerk, open the rolls.
Finance. Finance.
Eight ayes, 4 nays.
8 ayes, 4 nays. Okay, we'll see you this afternoon. Thanks.
This afternoon, great, thank you.
Okay, next on the list, Senator Reeves.
Good morning, Mr. Chairman.
Morning.
I have Senate Bill 1240. Mr.
Senator.
Chairman, Senate Bill 1240 was heard by this committee and through the floor last year. It came out of the Senate floor 40-0. The governor eventually vetoed the bill. I think he had some concerns with what it would do with pre-existing conditions. This is the exact same bill, and I can talk to the points about it if the committee would want to hear all those again.
No, I think, Senator Reeves, we heard this last year, and I think everybody recalls it. This is the short-term health care plans, 364
I do have an
days.
amendment.
Okay, is there a motion on the substitute? It's been moved and seconded. The substitute be adopted. All those in favor say aye. Aye. Any opposed? Okay, the substitute's before us. Senator Reeves.
Mr. Chairman, there was a couple of line items that we needed to fix at the request of some of those folks that are impacted by the bill, technical in nature. I think one was a period. So that's what the substitute does, but in summary, it's the same bill that we had last year. The next bill I have, I think, would hopefully clarify some of the concerns of why the bill was vetoed last year.
Okay. All right. I think the committee understands the bill. We've heard it. Are there those that wish to speak in favor of the bill? Are there those opposed to the bill?
Mr. Chairman, members of the committee, my name is Marvin Figueroa. I'm the Deputy Secretary of Health and Human Resources. The administration strongly opposes the bill.
Thank you. Are there others who wish to speak against it?
Good morning. I'm Ashley Kenneth for the National Multiple Sclerosis Society. We stand ready to work with the legislature to find solutions that protect patients and consumers by offering affordable and adequate health coverage. However, short-term plans are concerning. Short-term plans offer less expensive coverage but are not required to adhere to important standards, including the 10 essential health benefit categories, out-of-pocket maximums, and network adequacy. Short-term plans disproportionately harm individuals with pre-existing conditions such as MS because insurers offering these policies can either deny coverage or charge them much higher premiums. And for these reasons and more, we ask that you oppose this bill.
Thank you.
Good morning, Mr. Chair and members of the committee. I'm Jill Hankin from the Virginia Poverty Law Center. We oppose this bill for the reasons previously stated. The plans are deceptively provided to consumers with very limited coverage, and consumers will end up with no coverage when they need it and lots of unpaid medical bills. Thank you.
Thank you. Are there others? Hearing none, are there those who wish to speak in support of the bill? Seeing none, okay, the committee operates by motion.
Move to report.
Been moved and seconded that the bill be reported. Clerk, open the roll.
Thirteen ayes, 0 nays.
Okay, do you have anything else, Senator Reeves?
One more, Mr. Chairman, Senate Bill 1674.
1674.
And hopefully this will alleviate, God, if I could speak this morning, Mr. Chairman.
You're an Army guy. We'll
Roger,
forgive you.
sir.
Okay.
Anyway, what this bill does, go Army, we beat Navy. So, I don't know if that helps my bill now or not, but what this does is provides that any carrier offering short-term limited duration health plans may offer for sale a guaranteed option defined in the bill as a contract agreement between a covered person and a carrier that guarantees the option of the covered person to purchase a short-term limited duration health plan at a future date without re-underwriting. So the concerns that many have voiced about the
Is there a
ability-
substitute?
There is a substitute.
Okay.
I'm sorry, Mr. Chairman.
Been moved and seconded, substitute be adopted. All those in favor say aye. Any opposed? Okay, the substitute's before us. Go ahead, Senator.
Thank you, Mr. Chairman. So the measure specifies that a guaranteed option is not a health benefit plan and that a renewable guarantee may set a specific premium rate for any short term to alleviate some of those concerns on the money side. And that the limited duration health plan, it guarantees will be available to the covered person in the future. It builds really a safety net for those facing a lapse in health care coverage and either in the public or private sector. And that's what the bill does.
Okay, thank you. Are there those in favor of the bill? Seeing none, are there those opposed to the bill?
They're opposed to a guaranteed option.
Mr. Chairman, members of the committee, the administration strongly opposes this legislation.
Thank you.
Mr. Chairman, Jill Hankin from the Poverty Law Center. I think this bill actually makes it a little bit worse because it allows these short-term plans to renew much longer than they're currently allowed to renew. So even if the underwriting keeps the premiums steady, the fact that a consumer could continue to roll into year after year short-term plans is problematic. And this continues to also fragment our insurance market for other individual coverage, which can end up raising costs for everyone. Thank you.
Thank you.
Ashley Kenneth, National Multiple Sclerosis Society, and for reasons previously stated, we oppose this bill.
Thank you, Ashley.
Brian Donahue, American Cancer Society, Cancer Action Network. We oppose the bill.
All right, thank you. Okay, are there any others who wish to speak? Senator Reeves, you want to wrap up real quick?
Mr. Chairman, I would just say one of the concerns of the folks that spoke against this was that it would affect what's out there already as far as the marketplace. And the truth is, the Congressional Budget Office had some projections that average premiums for a benchmark exchange actually decreased by 1.5% for 2019 following the introduction of new short-term plans. So the truth is, it's actually short-term plans are helping with some of that cost. They haven't really been, like, there's not going to be this huge flood to go to short-term plans. So that's just smoke and mirrors.
Okay, all right. We've heard everything. Committee operates by motion. Been moved and seconded that Senate Bill 1674 be reported. Amendment in nature of substitute. Clerk, open the roll.
Twelve ayes, 1 nay.
That bill's been reported. Thank you, Senator
Mr. Chairman.
Reeves. Senator Chase. Senator Chase not here. Senator McBite. I know.
Good morning, Mr. Chairman and members of the committee. Senate Bill 1177. This is a bill that passed out of the Senate last year. You're familiar with. It requires the placement of an AED or an automatic external defibrillator device in health clubs. Last year, it passed out of the Senate with a fairly wide margin and was killed in the House sub by 1 vote. So I've talked to some of the members there, and they're still interested and maybe changing some minds over down the hall. So
Okay.
I've worked with.
I think the committee understands the bill. We've heard it last year. We acted favorably on it. Is there a motion on the bill? It's been moved and seconded that Senate Bill 1177 be reported. Clerk, open the roll.
Seven ayes, 4 nays.
7 ayes, 4 nays. That
Mr.
bill's
Chairman.
reported. Thank you, Senator McPike. Good luck in the House. Next, Senator Deeds. Okay, which one you want to do first?
The first one is 1475, and I've got a couple of amendments.
Okay.
With 1475, last year, this is for people that are in the marketplace. Last year, we expanded the definition of business to include sole proprietors. This simply extends that to multi-member LLCs and small corporations. With the amendments, it ensures the corporations are included, and it also ensures that only one policy per tax ID number is issued. And I think that's already the way things work, but it ensures that.
Okay. You want to report the amendments?
Thank you, Mr. Chairman. On line 241, after is, strike its sole and insert A. And on line 241, after member of, strike such sole, insert A. And on line 244, after respectively, insert, however, a health insurer shall not be required to issue more than one group health plan for each employer identification number issued by the Internal Revenue Service for a business entity without regard to the number of shareholders or members of such business entity.
Okay. And Senator Deeds, what's the bill attempting to do?
The bill is attempting to expand the definition of a small employer or one that's eligible for to get small business insurance in the marketplace to a multi-member LLC or small corporation.
Okay. You know, we're going to have a bill coming up before us that would allow association health plans where the Chamber of Commerce might offer a plan, and anybody who's a member of the Chamber of Commerce, which can include a one-person LLC, an SCP, anybody who wants to pay $25 and join the Chamber would be eligible. And then you'd have the massive benefit of a huge group. So hope when that bill rolls around, you'd act favorably, and if we might see it again in April, you'd act favorably again on it. But having said that, is there anyone who wishes to speak in favor of the bill?
I just wanted to let you all know that this bill's a good cleanup. I mean, it's just something that was left out of last year's bill, which basically gives an LLC access to the small group market.
How'd you let this?
So it's fine. It needs a little amendment that he has to make sure that they're under the same ID number. But
Okay.
other than that, it's fine.
Okay. Is there anyone opposed to the bill? All right. Committee operates by motion. It's been moved and seconded. The bill be reported. Clerk, open the roll.
Fourteen ayes, 0 nays.
Thank you, Mr. Chair. The second bill I have is 1734. It's a little more complex, but not that complex.
Okay.
1734, in 2018, Albemarle, Charlottesville, Greene, Fluvanna became the most expensive place in the country to buy an individual plan from the federal marketplace. Others can provide more expertise. The main driver was an extremely high rate factor Optima set for the Charlottesville area. The area rate factor essentially allowed the insurance company to charge Virginians in this market.
Is there a substitute? Appears there is.
There's a substitute.
All right, it's a motion on a substitute. Been moved and seconded that substitute to Senate Bill 1734 be adopted. All those in favor say aye. Any opposed? Okay. Substitutes before. Senator Deeds.
The area rate factor that was used allowed the insurance company to charge Virginians in this market that I described 58% more. This bill sets a hard cap on insurers, but rather does not set a hard cap on insurers, but rather requires additional disclosures to justify the factor if it deviates more than 15% from the weighted average of the area rate factor in other regions of Virginia. Only one insurer in Virginia in the history of the ACA has priced the market outside of the range set in this bill. The substitute addresses basically some concerns that were brought to us by the state, by the Bureau of Insurance. And
Okay.
there, as I said, there are others who can speak in more detail about the bill.
Okay, let's hear from those in favor of the bill. Working his way through. Yes, sir.
Thank you, Mr. Chairman. My name is Carl Quist. I'm an entrepreneur from Charlottesville. I'm also one of the co-founders of Charlottesville for Reasonable Health Insurance. It's a group of over 1,000 members in the individual market in Charlottesville, which includes Charlottesville, Albemarle, Fluvanna Green, and Nelson counties. I'm here to speak in favor of this, in support of this bill. In November of 2017, those of us who purchased insurance in the individual market in Charlottesville were shocked to learn that our premiums were tripling for the year. The $940 a month that I paid just to insure my family of 4 was tripling to over $2,920 a month. That's for the cheapest bronze plan available. That's a plan with a $14,400 deductible. Rates were rising nationwide, but Charlottesville's premiums became the highest in the nation. Not just the highest in the nation, but the highest by a wide margin. We now know exactly what went wrong last year, and we know how to fix it, and we know how to prevent it from happening again. The answer isn't some complicated regulation. It's merely a bit of additional transparency and disclosure that ensures that insurers are complying with federal and state regulations in their filings. This bill will prevent what happened in Charlottesville from happening in your districts. If an insurer wants to apply outlier level area rate factor adjustments, they can do that. We don't set any hard limits. It merely requires them to provide some additional disclosure to explain to the Bureau and to the public what those rates were based on.
Senator Norman has a question for you.
Are you implying that the insurers were not complying with the laws and the regulations?
The federal regulations require that they provide a detailed explanation of their area factors, and that did not happen in this case.
So, Mr. Chairman, it's your issue is disclosure rather than non-compliance in other areas.
That what we're looking for is disclosure, and the requirement is that there be disclosure.
Mr. Chairman, and do you think that the despised word of transparency is going to drive down rates?
We believe so. We believe if last year the insurer had disclosed the methodology by which they derived these factors, that the public would have had an opportunity to challenge them, and those area factors would have been lower. And they've since lowered them for the following year. So,
and I just have one more question for you. If you had available to you a chamber association plan, would you join that? That would bring the buying power of literally probably 20, 30,000 group health insurance policy. Would you be interested?
I'd have to see what that plan is. I currently.
Well, I'm sure you compare rates, but I can almost assure you it'd be less than $2,700 a month.
Oh yeah. And
okay. Yeah. All right. Thank you. Do you have others?
No.
That's fine. That's fine. Are there any opposed to this bill? Seeing none. Committee operates by motion. Been moved and seconded that the bill be reported. Clerk, open the rolls.
You're going to make me explain it on the floor. That's exactly
And maybe quiz you.
I appreciate that. Thank you very much.
Your bill's reported. Thanks, Senator. Senator Donovan. Senator Donovan not here. Senator Carrico. Senator Carrico not here. Senator Peterson. Senator Peterson here. Look at that, Senator Favola. By luck of the draw. It pays to hang around.
I have 2 bills, Mr. Chairman, and I guess I'll start with the lowest number, Senate Bill 1185, health insurance contraceptive coverage. There is an amendment.
Okay. It's amendment nature substitute or just
yes,
amendment?
it's an amendment in the nature of a
So
substitute.
motion on a substitute. Been moved and seconded to substitute be adopted. All those in favor say aye. Any opposed? Okay, substitutes for Senator Favola.
Okay, thank you, Mr. Chairman. What this bill does is it would require standard insurance plans in the Commonwealth to cover any FDA-approved contraceptive device or contraceptive drug at no copay. The substitute you're reading does provide for an exclusion for an employer who, because of religious reasons, would opt out of providing contraceptive coverage in the plans offered to employees. There's significant reasons why we should do this. About 40% of those who are covered under employer plans are benefiting now from contraceptive care, but we need to improve that number. And more importantly, there's a significant decline, a 46% decline in abortions when we have more available contraceptive care. So, for these reasons and others, I would strongly urge that the committee look favorably upon this bill and report it out.
I would think so. Okay, are there questions for Senator Favola? Senator Norman.
Senator Favola, do you anticipate that this is going to impact premiums in any way?
Actually, we talked to the insurance folks. They don't expect that there'll be a significant increase for two reasons. Many insurance plans are covering contraceptive care, some with a small copay. But the bigger reason is it's just far more expensive to cover pregnancies. So the I guess, cost and benefit analysis is it's worth it to cover contraceptive care at no copay.
Okay. Is there those that are in favor of the bill? Okay, seeing none, are there those opposed to the bill? Yes, ma'am.
Mr. Chairman, members of the committee, Felicia Preissner with the Virginia Catholic Conference. We appreciate Senator Favola's incorporating the exemption language. We've only just had a few minutes of reviewing it, but on its face, a few issues that we see is that there's no accommodation for employers with moral beliefs, which is currently in the HHS regulations. And additionally, it appears that there's some possible burdensome requirements on employers to provide a special statement of election to opt out of contraceptive coverage based on religious beliefs to both employees and prospective employees. So I'm not sure how you provide that notice to prospective employees, but it also appears that it singles out religious employers based upon their belief on contraceptives and provides for possibly a searchable public database on the Bureau of Insurance website for employers with sincerely held religious belief or moral convictions. So we see some issues with that as well, having them be a specific class of individuals that will be singled out and targeted potentially on this database.
Okay. Thank you. Are there others? Yes, ma'am.
Good morning. I'm Amy McInerney from Prince
okay.
William County. I'm here with concerns about freedom of conscience. I'm not asking you to accept my beliefs, but rather to respect them. Freedom of conscience is our first freedom. And I'm not here to convince you that the authentically pro-woman understanding of artificial contraception is the one that rejects contraceptives for exploiting women's bodies. There are people who think that contraception is not health care, and you may not agree with that, but I'm here to ask you, for those of us who hold these beliefs, for reasons of faith, for reasons of science, or just for moral objections, that we not be forced to participate in funding or providing contraceptives by mandating this coverage in health care. Small business owners and other employers who are required by law to provide health coverage to their employees will have no abortifacient-free options available to them. As amended, this bill does allow people to opt out for religious reasons, but there is no moral exemption, and that is a concern. This is a violation of our conscience rights. Thank you.
Thank you. Others?
Mr. Chairman, I'm sorry.
Yes.
There's some,
you have supporters.
There's some pro people.
Yes, ma'am.
I didn't realize they were in
Please.
the audience.
Hi, my name is Darlene Fluker, and I'm a community organizer at Planned Parenthood Advocates of Virginia. I'm also a constituent of Senator Norman's, but unfortunately we were unable to meet. But I do support this bill.
Okay, thank you so much.
I love you too, Lionel.
Yes, ma'am.
Hi, my name is Autumn Clemmis. I live in Richmond, Virginia, and I rely on birth control to control the debilitating symptoms I have of endometriosis, and a lot of people cannot afford that without health insurance, so I think it's very important that you support this bill for reasons other than just controlling having children. Thank you.
Thank you, ma'am. I'm going to start the timer here, looking at the number of speakers, okay?
Yes, my name is Adeline Bruger. I'm a concerned citizen, and I'm speaking in favor of Senate Bill 1132 because contraceptive coverage is good public policy. For the reasons previously stated, it prevents unwanted pregnancy, it prevents abortion and cost to the insurance company as opposed to paying for pregnancies. Thank you very much.
Thank you. Yes, ma'am.
Hi, my name is Maisie Bloffus, and I just graduated from the College of William and Mary in Williamsburg, and I support the Senate Bill 1185 because I can't take birth control pills because 5 members of my family have had blood clots, and this bill provides full coverage for forms of birth control other than the pill.
Thank you so much.
Hi, my name is Alex Hillebrand. I'm a fourth-year medical student and a resident of Arlington, Virginia. I go to medical school at a religiously affiliated institution in Washington, D.C. I've used birth control for as long as I can remember, and my school has opted to use the accommodation for religious exemption. Because of the final rules released by the Trump administration last year, they can opt out of that exemption if they want. And this is the same situation that Virginia women currently face, and it puts thousands of Virginia women at risk just like me. I learned in my classes that the best forms of birth control are LARCs, or long-acting reversible contraceptives. And I think this bill is really important to protect Virginia women so that they don't end up in a situation like me due to religious exemption. Thank you.
Good morning. My name is Nicole Libertor. I am a resident of Annandale, Virginia. I have been on birth control since I was 14 years old and couldn't often afford it. So I urge you to support this legislation. And I also, if I may submit it to the committee, have 6 pieces of written testimony from activists who believe in this bill who are not able to be here today, if I may submit that.
Thank you.
Hello, I'm Tanisha White, a resident of Richmond and someone who lives with polycystic ovarian syndrome, which is regulated by birth control. So I urge you to support this bill.
Thank you so much.
Hello, my name is Michelle Wooten. I'm from Newport News, Virginia, and I urge you to please support this bill.
Thank you. Very nice geographical spread. Hang on a minute, Senator Favola. Mr. Gray, come on up here.
Now, the ladies love you, Mr. Gray.
I noticed representing the health insurance plans, you sat over there in the corner and didn't come forward. If we start down this road of eliminating copays, should we not do it for all pharmaceuticals? Is there no financial cost to this? No hit on anybody's health insurance policy? So maybe we ought to expand this bill to do away with all copays on pharmaceuticals. I'm sure that would be very popular. Can you express an opinion why you didn't get up and talk to this one?
Mr. Chairman, this bill deals with what is already offered in the ACA with no cost share. It's already required by the law. The bill isn't necessary because the ACA already covers these items, and we already cover them without a cost share. So that's the reason why it's kind of hard to get excited about the legislation. It's not necessary because we already have it on the books. I think the reason that the patron's offering the legislation is that she's worried that the ACA may not survive, or there may be changes to it. That's what I've heard from the patron. So that's basically the explanation of the way we see the bill.
I thank you for informing the committee. Senator Norman.
Senator Favola, do you agree with the assessment that Mr. Gray just offered us?
Well, actually, I talked to Mr. Gray about my health insurance essential benefits, which is the next bill coming before me.
Okay, no, I'm interested in this. Do you agree what he has said, that it is already the law under ACA?
Under ACA, but there are lots of other permutations, there are lots of other plans, so my intent, I think, was accurately presented. I just want to make sure that we have this on the books in Virginia.
Senator Norman.
Is the legislation really necessary? I get the,
Well,
I
I
get the
think
populism of it, but I mean, is it really necessary?
I believe it is because I think it's such an important piece of women's health, families' health. I think if we really care about family planning, if we care about having healthy babies, then we should make contraceptive care available. We're asking everybody, men and women, to be responsible for their actions. We're asking folks to take charge of their lives and move forward with managing their health. And this is a preventive measure. Yes, I think it's important.
Okay. All right, we've heard from everybody, and committee operates by motion.
I move it be reported.
Been moved and seconded that the bill be reported. Clerk, open the roll.
Five ayes, 10 nays.
Okay, the bill fails to report. Senator Favola, you have another bill.
Okay, my second bill is Senate Bill 1344. This is an essential health benefits bill, and I will give you the context for this. Under our statutory authority now, the essential health benefits links back to the Affordable Care Act. So this bill does two things. It links it back as of January 1st, 2019. Oh, and forgive me, there is some line amendments, or
Is there line amendments or a substitute?
Mr. Chairman, we have line amendments. On line 210, after Plan SEM, insert and on line 211, after arrangement, strike for plans provided pursuant to Article 17, Section 6.2, 951 et sec of Chapter 8 of Title 6.2, and plans provided under Section 23.1, 106.
Okay. Is there a motion on the amendments? Been moved and seconded. The amendments be adopted. All those in favor say aye. Any opposed? Okay. The bill's before Senator Favola.
Thank you, Mr. Chairman. So, as I was saying, we tie back these essential health benefits, which are already on our books, but I just tied it back to the January 1st, 2019 regulations, Affordable Care Act. This would be under the PPACA. And what it does is it takes the prevention and primary care services that are already on our books, linked back to the Affordable Care Act, and extends them to short-term plans and catastrophic health insurance plans and association health plans. My intent here is to ensure that more plans actually, other than our standard plans, that more plans actually cover essential health benefits. And these essential health benefits are really key, and they're key to keeping people healthy. They're key to avoiding higher health care costs. And I think they're just basic common sense. Under preventive services, we have things such as immunizations for children. We have we follow comprehensive guidelines for evidence-informed preventive care. We follow guidelines issued by CDC. We follow guidelines issued by the Health Resources and Services Administration. This bill actually, or this request, came to me from a group of pediatricians in Virginia and the Medical Society of Virginia and other physician groups that really, their passion and their mission is to keep people healthy.
Okay, thank you. Are there those in support of the bill? Briefly.
Yes. Good morning, Mr. Chairman, members of the committee. I'll be very brief. Amy Parent-Seibert on behalf of the Virginia chapter of the American Academy of Pediatrics, and we do support this bill. We think it's really important when folks are signing up for short-term and association health plans that they are able to make sure that we have a minimum set of standards for their care. We don't want parents to sign up and think they're going to have care for their children, well visits, immunizations, and sick visits, and find out that they don't. And we think that's a really dangerous thing because we know that healthy kids lead to healthy adults, and we think that's an important thing. So thank you, sir.
Thank you, Amy. Are there others? Does anyone oppose this legislation? Yes, sir.
Hi, George Clark, York County. I'm an insurance broker, and I work with a few associations. I actually spend a lot of time with the Department of Labor helping craft these association healthcare plans. One of the key things about these is that pre-existing conditions are covered. You cannot discriminate against those. All of the care that everybody mentioned is going to be covered, but it'll be with a copay. Because one of the problems we're having now is all of these free services we're told we're getting when we buy insurance, we can't afford them anymore. You know, families are paying $2,400 a month for all of this free stuff. We'd just like to have all of these things going to be covered. Mammograms are covered, colonoscopies are covered, everything is covered like beforehand. Immunizations, all of it, but there will be a cost-sharing portion with that. So I oppose this. Thank you.
Okay, thank you. Yes, ma'am.
Mr. Chairman, members of the committee, Felicia Preissner with Virginia Catholic Conference. We are concerned predominantly with line 183 through line 186, which mandates that health carriers shall provide preventative services issued pursuant to the ACA, essentially, which includes coverage of FDA-approved contraceptives, which includes abortifacients and sterilizations. In light of that language, we didn't see any type of exemption language or religious accommodations of any sort in direct contravention of Burwell versus Hobby Lobby and Little Sisters of the Poor. So we oppose this bill.
Thank you very much. Yes, ma'am.
My name is Monica Darnell. I'm from Arlington, Virginia, and I oppose this bill.
Thank you. Any others? Okay, Senator Favola, would you like to wrap up?
Again, these essential health benefits are already required, and I think that they're much needed, and I would ask that we embrace my bill. I do believe that some of the short-term plans do cover these essential health benefits, but not only do they enable people to stay healthier, they really are quite cost-effective. So,
Mr. Chairman.
Senator Stanley.
Mr. Chairman, Senator Favola, if you look at 38.2-3442, lines 164, and starting at about 168 and going all the way through to the next page, 182, you're striking all the evidence-based criteria that has worked up to this point so far.
we moved it around. It was that was a drafting decision to move it up front to lines 123 to 135. It looked like we removed it. I had the same question, Mr. Chairman, Senator Stanley, but they put it in a different place. And you may ask the drafter. She perhaps can elaborate more than I just did.
Thank you.
Chrissy, you want to weigh in?
Sure, thank you. Yes, we just moved the language that's on line 169 that's stricken, and we made it into a definition, which we moved to lines 123 to 135, and that way we could use preventative services as defined throughout the bill.
Counselors, that answer your problem?
It does look strange. I appreciate it.
It does look strange. Is all of it? I mean, so you didn't take out one word in the evidence-based?
There's no substantive differences. There might be, the words might be different, but substantively, we took the material from those lines and just made it a definition so that we could clarify the use throughout the bill.
Thank you, Mr. Chairman.
Okay. Does that answer everything? Okay, the committee operates by motion.
Moves report.
Been moved and seconded that the bill be reported. Clerk, open the roll.
Four ayes, 11 nays.
Bill fails report. Thank you, Senator Favola. Next on the list, Senator Donovan. And you have half the docket, so.
I will do my best to be as efficient as possible,
Okay.
Mr. Chairman. I'll start with 1598.
All right, 1598.
This is a bill that it does have a substitute or
We have a substitute on 1598.
1598 Board of Corrections minimum standards.
Is there a motion on the substitute? Do you have a substitute? Wait a minute, whoa. Oh,
My bad, Mr.
1598 may
Chairman.
not be in this committee.
I don't know
So,
where it is.
well,
Okay, Mr. Chairman,
Let's
I'll
try
start
15.
with 1590. That be okay?
Do we have 1590 in here?
Guys, I think I'm so sorry. I've got some wrong things in here. 1596.
We got 1596, Senator.
I'm really sorry about that. 1596.
It's embraced in the committee. Okay.
1596 is a bill that it's a bill back from last year. It is something I called. Let me make sure I'm on the right page. No, sir, this is a new bill this year. This is a bill that will work to This will address a problem in the cost of prescriptions that individuals are suffering as we go forward. We've got to get down to the root of the problem in healthcare. Some of that is the cost of our health insurance, and some of that is the cost of healthcare in general. I'm sure you've all had experiences. I've had many patients report to me and friends. They go to the pharmacy, they go to fill a prescription given by their doctor, and they're told by the pharmacist, if you get this prescription on your plan, it's going to cost you $250, but it's going to count towards your deductible. But I can get you this prescription for a lower price, $100, but it won't count towards your deductible. What do you want to do? And patients are making choices to choose the higher prescriptions. This bill proposes that we will essentially direct the insurance companies to accept the lower price cash options or other coupon options as counting towards the deductible, and thereby make it less expensive for patients.
We're all trying to do that, Senator Donovan. Are there questions for the patron? Okay, are there those in favor of the bill? I'll stop. Are there those opposed to the bill? Oh, in favor. Yes, ma'am. I'm sorry. Room is crowded, so I'm going to have to put you on the clock. So
Yep.
fire away.
I'm Colette Kulianis from the National Hemophilia Foundation, and we are in support of the bill. Hemophilia is a chronic, lifelong disease, and our patients require clotting factor that they infuse to stay healthy. And there are no generics or biosimilar equivalents available for hemophilia, not in this country or anywhere else in the world. If a member can't afford their medication, they're left with only one option, and that would be to be hospitalized or visit the ER. And so for those reasons, and I'm sorry, and the other thing I want to make sure I add is that we're not mandating that plans accept copay cards or assistance, but we are saying that if they do accept them, that it counts towards the member's out-of-pocket. Thank you.
I'll take it up. Right. Yes, sir.
Bruce Silverman. I'm a physician here in Richmond. My patients generally take 12 to 15 medications. Many of them use copay assist cards. They need to have this applied to their deductible. Personally, I take Cerezyme. It costs my insurance company $500,000 a year. My copay assist card covers my $6,700 deductible and out-of-pocket. Anybody who has a chronic disease will need these copay assist cards to afford these very expensive and serious medications. I urge you to support this bill. The Richmond Academy of Medicine also supports this bill, as well as the Medical Society of Virginia.
Thank you, sir. Yes, sir.
Mr. Chairman, members of the committee, Brian Donahue, American Cancer Society Cancer Action Network, we support the bill.
Thank you.
Mr. Chairman, members of the committee, Kelly Fitzgerald, on behalf of the Virginia Breast Cancer Foundation and the Virginia Hemophilia Foundation, they strongly support this legislation.
Thank you.
Mr. Chairman, Jill Hankin from the Poverty Law Center. This is about the deductible that consumers have to pay for before the insurance plan is going to pick up all their costs, right? Yeah. It doesn't matter if they pay that it shouldn't matter that they pay the deductible from their own pocketbook, from their grandmother's pocketbook, from a copay card, from an insurance, a pharmaceutical company. It doesn't matter. If they're purchasing the medical care, whatever costs are incurred, whoever's paying for it, that should count towards the deductible. And that's what this is about. Right. Thank you.
Thank you.
Mr. Chairman, Ashley Kenneth, National Multiple Sclerosis Society, and we support this bill.
Thank you so much. Okay. In support? Let's hear from the opposition.
Mr. Chairman, I'm Doug Gray from the Virginia Association of Health Plans. Drug costs are out of control and they're growing. For the first year ever, drug costs and prescription costs are the largest portion of your premium dollar. It's 23 cents. What's happening in this case is pharma companies are paying the patient to take the most expensive drug. And what that means is the pool pays more all the time. And so what they're doing is paying them their entire cost share to encourage them to use the most expensive drug, which means that they can reach into the pool and take what they want. Humira went up 250% over the last 5 years. So once they can get the cost share out of the way, they can reach into the pool and raise the price each year, year after year after year. I've distributed a list to you of 10 different drugs that have gone up over a 4-year period of time between 163% and 652%. You will recognize many of the names because you've seen their ads, because this is how it works. You advertise it, you heavily push it to both physicians and the patient, and if you're the only game in town, you don't even have to offer a coupon. Why would you? I mean, you'd offer it once, and then you can reach into the pool and take what you want. This is how you drive the cost of drugs up. What the real purpose of this is to get people on the name brand, because eventually a biosimilar or a generic will come along. And the more people who are on the name brand and their cost share is already covered, the less likely they are to adopt the lower cost drug. So when a new biosimilar comes along, which it has in Europe for many of the expensive drugs, but not all of them, when it arrives here, the adoption will be very low and your costs will be very high. So the bottom line with this approach is it sends the wrong message and encourages people to overspend. And its purpose is to defeat the adoption of alternatives when they come along by getting it out of the way now. If pharma really wanted to help the patient, they would give them a coupon every month to pay for the cost share. We honor the coupon in every case. This is not about honoring the coupon or getting access to the drug. What this is about is when the company's raising the price every year and also paying the cost share, we don't think it's appropriate to count that towards the deductible. So that's what this is about. And pharma could solve this very simply by just giving them a coupon every time. If you pass this bill, we'll just give them a coupon once. And then I can reach into the pool every time. What this does is increase the overall healthcare costs, and it does it intentionally. And it has a long-term effect, too. It's a master strategy, and each and every one of these groups are dependent on these drugs because, frankly, there isn't a lot of competition, and the drug company can set the price wherever they like. So, and I want you to understand that this bill, I can't stop somebody from paying somebody else's cost share. I don't know when they do it. And so they do get credit when somebody else pays it for them or reimburses them, because that's exactly what's happening now. Humira has an app. If you use their drug and you register and you take a picture of your bill and you send it into them, they send you a check. How would we know who paid the bill? We don't. All we know is the consumer paid the bill. We don't know about what's happening behind the scenes. So what this is a scheme, and it's a very effective one, and it's working. That's why drugs are the highest percentage of your cost share dollar. So our appeal to you is don't make a bad situation worse.
Okay, Senator Donovan, you want to respond?
Thank you, Mr. Chairman. I do. And I would say there is plenty of blame to go around on why pharmaceutical costs are as expensive as they are. And this is the beginning of trying to resolve that problem. This is, I hope, an opportunity for there to be a little bit more competition in how prescriptions are priced. There are many prescriptions that are preferred drugs on the PBMs that are not necessary to be the preferred drugs and are much more expensive than other options. So I think somewhere we have to start bringing some competition into how the PBMs negotiate. I think above all, the patient should be held harmless for the money games that are going on with healthcare right now, and I hope you will support this bill.
Okay. Are there questions? All right, the committee operates by motion. Been moved and seconded. The bill be reported. Clerk, open the roll. Okay.
15 ayes, 0 nays.
All right, thank you. Senator Donovan, next
Thank
bill.
you, Mr. Chairman. 1611 is healthcare shared savings. This is a bill I was alluding to before. This is a bill that comes back to you this year. We looked at it last year, and essentially this bill directs health plans to create an interactive relationship with their patients where they let them know all of the places they could go to get a procedure done. And if the patient indeed chooses a lower cost option, the savings that are realized by the insurance company paying less for that procedure are then shared with the patient. It's really interesting, Mr. Chairman, that over the last year, and there's a substitute that we have, over the
There's
last
a motion
year.
on a substitute. Been moved second that the substitute be adopted to 1611. All those in favor say aye. Any opposed? Okay, substitutes for Senator
Thank you,
Donovan.
Mr. Chairman. Over the last year, our own state employee health plan has offered this service, has initiated it. It has been successful. It has been commended by the governor as being a great innovation in Virginia. I hope we can extend this beyond just the state employees and make sure that every patient in Virginia has the option to begin to make better, more cost-effective, high-quality health care decisions and share in the savings that are associated with that.
Okay, thank you. I think we understand the bill. Are there those in favor of the bill?
Thank you, Senator Donovan.
One
Mr. Chairman,
side.
Andrew Lamar with the Opportunity Solutions Project. We brought this bill and had this conversation over the interim. We were pleased to work with Anthem and others to come to consensus on this bill. Hope it'll be the pleasure of the committee to support it. Thank you very much. And I know Lindsay wanted me to mention Anthem supports the bill. Thank you very much.
Okay, thank you.
Mr. Chairman, I'm Doug Gray on behalf of the Virginia Association of Health Plans. We support this compromise. We think it starts it off at the right place and puts a lot of extra changes in the bill to make it workable. And we think it's important that the consumer have a role in the process. And what this does is encourage them to use their cost share as a motivation to shop for a better deal.
Okay, thank you. Is there anyone opposed to the bill? Seeing none, the committee operates by motion. Been moved and seconded, the bill be reported. All clerk, open the roll. Thank you.
14 ayes, 0 nays.
Okay, that bill's reported. Senator Donovan, what do you got next?
Thank you, Mr. Chairman. I have Senate Bill 1685. This is a bill to help us address some of the mental health crises that we have in Virginia. We know that there's a real shortage of mental health providers, but what makes that even worse is that when mental health providers are hired, I'm sorry, there's a substitute here too. The substitute.
Second.
My man.
You got a motion, seconded.
You've got substitute in front of you, Mr.
That's
Chairman.
been moved and seconded. All in favor of substitute, say aye. Aye. Any opposed? Okay, substitutes for Senator Donovan.
So, Mr. Chairman, as these mental health care providers begin to initiate their services to patients, they are not reimbursed for those services until they are fully credentialed by the health plans. In Virginia, we have a permission for physicians who are waiting to be credentialed to provide services and retroactively bill so that that income is not lost while they're waiting to be credentialed. And this credentialing can take 90 to 180 days. And so this is simply a bill that will ensure that mental health providers also can retroactively bill for those services, so we have no further delay in providing mental health services in the state of Virginia as new hires come on board.
Okay, thank you. Let's hear from supporters. Yes, sir.
Mr. Chairman, members of the committee, thank you so much. I'm Stephen Stark. I'm with the Virginia Association of Community-Based Providers. We support this bill because this measure will allow us to see patients far sooner by shoring up our professional workforce and allowing our professionals to actually see clients sooner because of the retroactive billing. As Senator Donovan mentioned, we have a current wait list of 60 to more than 180 days waiting for credentialing. That means our clients, our patients will not be seen by our professionals who we are paying while we're waiting to make them productive. This legislation already exists and is applied to physicians in physical health care. The same issues and the same remedies are needed for behavioral health, and therefore we'd ask that you apply this legislation equitably. The financial risk will rest solely on that of the providers if, in fact, the application for credentialing fails for each of our practitioners. And we also ask that this bill be approved with the two amendments to ensure the equitable application of this service among those with economic disparities, as well as the removal of the mandate that would require one licensed practitioner to every 2 unlicensed practitioners, because that is not viable or sustainable. And the bill as written, we would ask that you approve it completely. It will allow us to provide quick, efficient, and high-fidelity services to people who are most in need in the great Commonwealth.
Thank you, sir. I assume the amendments are in the substitute.
They are. And, Mr. Chairman, that just directs archaic language about what the ratio should be to licensed and unlicensed. It also does direct Medicaid to participate in this paying for services retroactively when somebody is credentialed.
Thank you. Are there others? Yes, ma'am, briefly, please.
Good morning, Mr. Chairman, members of the committee. My name is Jennifer Faison. I represent the Virginia Association of Community Services Boards, and we support this bill.
Thank you, Jennifer. Yes, ma'am.
Good morning, Mr. Chairman. My name is Jennifer Fedura. I represent the Virginia Network of Private Providers, and we also support this bill.
Thank you. The Jennifers are here. Okay, is there anyone opposed to the bill? Ah.
I'm actually not.
Oh. Then why are you stepping up there?
Well, because it's not quite as simple as.
Go ahead. Fire away, Doug.
Mr. Chairman, I'm Doug Gray on behalf of the Virginia Association of Health Plan. We have, this really is mostly a Medicaid-related issue because mental health services that are provided by these providers are predominantly coming through the Medicaid managed care plans, and there are 6 of them. We are required by contract to make sure that they're not on the OIG exclusion list before they treat our Medicaid beneficiaries. So there may be a little bit of a conflict with what's in the contract. So we need to work with the patron to make sure that that conflict isn't still there. The other thing I would just remind folks is the original structure of the bill is only in regard to agencies that already have a contract with an entity. If somebody is new and they're starting a new agency, this isn't going to apply. And that's okay. I mean, we have to have some knowledge of what we're doing if we're going to allow the provider to have it, to start treating patients. And they do not get paid right away. They get paid upon credentialing. So credentialing is still important, and they still have to do it. So there are a couple things we might have to work through depending on DMAS's analysis of the contract. So I just want to make sure everybody knew.
We're going to move this bill through, and I'm sure Senator Donovan will work with you to ensure that those discrepancies. So the committee operates by motion. Been moved and seconded. The bill be reported. Clerk, open the roll.
And
Okay,
I
that
will
bill's
work with
reported.
DMAS.
Senator Donovan.
Thank you, Mr. Chairman. Now we're on to Bill 1607.
1607.
And I believe there's peace in the valley on this one, Mr. Chairman. This is a bill that has been.
Is there a substitute? There is a substitute.
I have
The motion
substitutes on everything. Yes, sir.
Been moved and seconded. Substitute 1607 be adopted. All those in favor say aye. Aye. Any opposed? Okay. Substitutes before us.
This is just directing prior authorization and authorization for surgical procedures and prescribing of medication. I don't know if you've heard as much from your constituents as I have on some of the challenges of this, but this specifically makes some changes. If a surgery or invasive procedure that is done has been pre-approved and during surgery something is found that is different or in addition to that, it is covered. Prior authorizations for medications, the carrier must have a 24-hour call coverage for the physician even on weekends so that we can get those through if needed. It protects a patient if they switch carriers and the former carrier had required a prior authorization so that patient can stay on the medication for up to 30 days without the new carrier requiring a prior approval. There is, if a carrier requires a prior authorization for a drug and the dose changes, a new prior authorization is no longer required. There's several other just good business practice changes in this bill that make sure prior authorization does not obstruct patients getting appropriate care and patients getting appropriate pay. Physicians getting appropriate
Call that change orders and ship repair. But are there those that wish to speak in favor of the bill? Are there those opposed to it? Oh, you want to speak in favor of the bill? Oh, you have to hustle up here.
Look at this unit.
Maybe you haven't eyeballed the docket, Doug, but Doug, talk.
Mr. Chairman, Scott Johnson from the Medical Society and the health plans sat down and worked in the off session quite a bit on this. We had multiple meetings and really worked through a number of efforts in a very substantive way to get to this point. And I just wanted to make sure that we recognize Scott and the Medical Society for their effort and my members for their effort to come together and create a Peace in the Valley product. So
we're going to have that on every bill?
Not on every bill, sir.
Okay. All right. I was afraid of that.
Mr. Chairman, I want to make sure Doug's okay. Are you feeling okay today?
All right. I have a motion to report. Is there a second? Been moved and seconded that the bill be reported. Clerk, open the roll.
$15 ayes, 0 nays.
Okay, 15 ayes, nays. The bill is reported. Senator Donovan, you're on a roll.
Thank you, Mr. Chairman. This is Senate Bill 1689, and this refers to association health plans or benefits consortiums. I don't know if there are other bills on the docket that are similar.
Could we have?
And we have a substitute.
What was the list? I know you provided it to me, and in the snowball of paper I have. I know I have one, Senator Donovan. Oh,
Chrissy.
okay. How many of these, how many association? I know I have one. Is it just Senator Donovan and I have one? Right. Okay, I'm going to make a motion that my bill be rolled in, my bill Senate 1351 be rolled into Senator Donovan's bill and both chief co-patrons. Is there a second? Second. Okay, it's been moved and seconded that my bill be rolled. Clerk, open the roll.
Move substitute, Mr. Chairman.
Okay.
15 ayes, 0 nays.
Okay, the motion's been made. Senator Donovan, I trust you to be my captain. Okay, there's a motion on substitute. Been moved and seconded to substitute to 1699 be adopted. All those in favor say aye. Any opposed? Okay, Senator Donovan.
Mr. Chairman, I believe that this substitute also creates peace in the Valley. This is Benefits Consortium, which we entertained last year, and that would allow large membership organizations like the Realtors, like Chamber of Commerce, to come together and create a large group health plan. Large group health plans are some of the most cost-efficient and effective health plans that we can have, and as a result, individuals that are purchasing insurance in the individual marketplace can move to an association health plan and save as much as $10,000 a year. We hear about people who are paying $2,400 a month. That's a big deal. People can move from the small group health plan sector and save $4,500 a year. This is an opportunity for us to offer additional health plans to Virginians who are suffering under the burden of the increased costs that we've seen over the last many years in the health plan market. So there is information and edits in here, amendments from the Board of Insurance, who is concerned about solvency of these groups, and they have added some language to ensure that they are solvent and have appropriate protections. There's a history in Virginia where some plans went under and people were left without coverage for their services, and we've made sure that that is okay. But this, I think, is something that can move forward and actually get signed this year, Mr. Chairman.
Senator Donovan, what we have here is not a new concept because it's going on, and I believe for private colleges and universities.
Indeed, it's something Virginia's already endorsed through private colleges and through the Bankers Association.
To the bankers. So we're just trying to give that same opportunity to everybody in Virginia.
That is absolutely right.
Absolutely. Okay, who could be opposed to this fine bill?
I can't imagine.
Mr. Chairman, members of the committee, the administration strongly opposes this legislation.
All right, thank you. Oh, Senator Stanley has a question. Why?
Why?
Mr. Chairman, members of the committee, we believe that the further you segment the population, so the more you take people out of the risk pool, the more it increases prices for the individuals who remain in the risk pool. And for those reasons, we oppose, but we're willing to work with members of the committee to find a better way for us to provide better coverage for individuals in Virginia.
Let me ask a question, if I could.
Yes,
okay,
sir.
We've expanded Medicaid. Okay, so that takes the indigent and the working poor off of the rolls. They are now insured. So who is left for the poll other than those that are working? And why shouldn't we give the people that have the opportunity to work the opportunity to join one of the association? Because basically, if you expanded Medicaid, and we have up to significant poverty levels, so the working poor have health insurance now. So the remaining population earns enough money with some company or another to not qualify for Medicaid. Why wouldn't we give those folks the ability to get into an association health care plan rather than force them into a pool that's costing an exorbitant amount of money, because that population shouldn't exist now? So can you answer that?
Well, Mr. Chairman and members of the committee, at the direction of the General Assembly last year, we held a working group to look at how you strengthen the marketplace in order for you to reduce premiums and also increase competition. What we found in that study is that association health plans, again, increase premiums because you're taking folks out of that risk pool. But there are ways that we can strengthen the risk pool. One, we could establish a state-based marketplace. We could look at a reinsurance process. We could better regulate some of these short-term limited duration plans as well as association plans, and do a better job at also outreaching to ensure that we have the healthiest risk pool possible. And so we have
Were there any bills submitted as a result of the study group? I'm not aware of them on the docket. Did the governors submit any bills as a result of the study group?
Mr. Chairman, members of the committee, we did not submit legislation in this session, but we're working on putting forward ideas.
I would hope you'd take this message back and to say who's left. It's the people who are working primarily for small businesses that earn enough where they don't qualify for Medicaid, but find themselves in a bind with their small employers. And trust me, I was one of them, although I had a larger group than most, who struggled every year during health negotiation times. And I would have dearly loved to have the buying power of the Chamber of Commerce, which I belong to join a very large group. And it just is intuitively knowledgeable to me that the bigger pool that you have, the more competitive that the people that Doug Gray offer, not going to want to lose that policy. And you represent a bunch of different clients. All of them will probably get very competitive and sharpen their pencils in order to get perhaps 100,000, 150,000, maybe 1 million, 2 million Virginians in a single pool. And I would hope, and I don't know why it didn't come up during the study group, but I'd hope you all go back and take a look at that. And, it's when you looked at the exit polls, the number one reason for people, when they left the exit polls, what's number one on your mind? Healthcare costs. I can show you a stack of letters on my desk right now, when we're going to get to this subject about balance billing in a little bit, of people who have just been raked over the coals and then put into collection agencies on balance billing that they had no idea it was coming. And I can show you a stack. We've got to get a handle on this. And so we're going to take a look at this bill and move forward. But thank you, Melvin. I appreciate it. Yes, sir.
Mr. Chairman, members of the committee, Doug Stolte at the Bureau of Insurance. We don't have a position on the bill. We appreciate Senator Donovan putting forth the substitute with the amendments that address our solvency concerns.
Okay,
So
thank you so much. Okay, are there those in support of the bill?
Mr. Chairman, Keith Martin with Virginia Chamber of Commerce. We believe this bill affords an important tool for associations to use to provide health options for small employers, to provide health care to their employees, so we support the bill.
Thank you.
Hi, George Clark again. I've been working with a lot of associations over this. Definitely support this. This allows small business to finally group together and be like a large business, where Amazon can get products and in pricing that a small business can no longer get. So please support this. This is really going to make a significant impact on small businesses.
Are there others? I want to make a final comment. This bill is going to come, I suspect, to the governor's desk again. I would hope that when it gets up there, you all take a look at it and see if there's some amendments rather than a blank veto that can move this forward, because I think we're onto something. And when you take into calculation those on Medicaid, I think you're going to find that there's the requirement for pools are going to disappear, because it's only certain populations. I think the requirement for pools are going to disappear in Virginia by allowing association health care plans and having expanded Medicaid. I just don't see who wouldn't be covered. Yes, Senator Sproul.
Last gentleman who that spoke about allowing the Chamber of Commerce and these other groups to get together to provide for the small man, as you want to call them, working. Who can watch them to allow them to make sure they don't outprice the small folks who had the small business or the small person who are working? Who can look out for them? Because now you can allow them to do that. Next thing you know, the Chamber of Commerce, I don't trust the Chamber of Commerce. They don't mean that to me. So who can watch them?
Senator Donovan.
Mr. Chairman and Senator Sproul, number one, these would have oversight like a large group plan does, which is federal through ERISA. The second thing is we have added language and amendments as recommended by the Board of Insurance to ensure that there are safety checks and balances in this bill, so that we do have protections for the individuals that would choose to be insured this way.
Thank you.
Okay, thank you. All right. Mr. Gray.
You made a few comments about how health plans see this, and so I wanted to make sure that they actually reflect our views. We don't oppose association health plans. We are the administrator of them, and we do that today under Virginia law, and there are association health plans that we administer today, and you're required under current state law to have a license in Virginia to administer a health plan. So what's different about this bill is that I think it allows somebody who's licensed in another state to administer it, and that is where there might be a teeny bit of friction. But it isn't that we oppose association health plans or the concept or the business opportunity. So I just want to make sure you all understand we aren't in a position of opposing the concept of association health plans.
Mr. Chairman?
Yeah. Senator Sproul.
Question, Mr. Gray? Now, you got sparks on that. Now, the outer state, if that can create a problem as far as we one time had some concerns about these out-of-state companies doing business in Virginia, how we monitor them, how we regulate them. Would that create a problem with the insurance company that you represent in state?
Mr. Chairman, that'd be an issue. Mr. Chairman and Senator Sproul, that would be a question better asked of the Bureau who runs the regulatory structure. I mean, we obviously operate under the existing law, which is we have to be licensed in Virginia.
That's a question then to someone ask that question, Mr. Chairman?
What's that, Senator Sproul?
Okay, someone else asked the question. I'm concerned about out-of-state regulating stuff in Virginia.
Can I have the help from Board of Insurance? I actually think that the Board of Insurance amendments here standardize what oversight there would be, whether you're in-state or out-of-state, but I'll defer to them.
Yes, Mr. Chairman, members of the committee, Doug Stolte, Deputy Commissioner of Financial Regulation. The bill is limiting, it's creating basically a new company type for these self-insured MIWAs, Association Health Plans, Benefits Consortiums. It's for Virginia MIWAs, these new company types. So it would be limited to them. The foreign multiple employer welfare arrangements or benefit consortiums, they would still have to apply with comply with our current regulation, which requires them to be either fully insured or become an insurance type of entity themselves.
Thank you so much.
Thank you.
You're welcome.
Okay. Yes, sir. Briefly.
Sorry, may I miss my turn? I'm Brian Donahue, American Cancer Society, Cancer Action Network. It's our national policy to oppose all association and short-term health plan bills. So unfortunately, we are in opposition to this.
Okay.
Mr. Chairman, Ashley Kenneth, the National Multiple Sclerosis Society. The National MS Society is concerned that consumers may be attracted to these types of plans because of the lower premiums, but they may not realize how limited the coverage is until it is too late. Even if these types of plans do choose to cover essential health benefits or people with pre-existing conditions, they could charge them substantially more and leave people in financial distress. Thank you. We oppose this bill.
Okay, thank you.
Jill Hankin, the Virginia Poverty Law Center, Mr. Chairman. We oppose the bill because it further fragments the individual market and will leave people with unexpected medical bills. Thank you.
Mr. Chairman, I'll just respond by saying that 45% of the insurance marketplace in Virginia is large group insurance that's covered under these type of association health plans, and that's some of the best insurance we have in Virginia.
I was just going to say, Senator Donovan, that, you know, based on the last few speakers, maybe we ought to do away with the Bankers Association health care plan, and maybe we ought to do away with the small colleges and universities health care plans, because obviously they're not covering the kinds of things, but it's exactly the opposite. So I think of that. Okay, committee operates by motion.
Move to report.
Been moved and seconded that. Oh, I'm sorry. And Senator Vogel asked that strike that. Is there a motion to incorporate Senator Vogel's 1712 into this? Been moved and seconded. But clerk, open the roll. We're just voting to incorporate Senator Vogel, so we have one last bill to deal with in this committee, Senator Sproul. Okay, thank you.
13 ayes, 0 nays.
Okay, 13 ayes, 0 nays. That bill's incorporated. Now the motion is to
Move to report.
move to second that the bill be reported. What's that?
Re-refer to Senate Finance.
And re-refer to Senate Finance. Clerk, open the rolls.
$11 ayes, 4 nays.
11 ayes, 4 nays. Okay, that bill's supported. Senator Donovan, do you have another one?
I do, Mr. Chairman.
Thank
I
you,
know
sir.
I've
Thank you,
imposed
sir.
upon.
May I have another? Okay.
Yes, I know I've imposed upon the committee. I have saved the best for last.
Ah,
So
the
if I
best
could
for last.
just have your attention for a few more minutes, I want to talk about a solution that was referenced by the administration to help come up with a new and inventive way to fix the individual marketplace.
Okay.
Mr.
And-
Chairman, excuse me. Mr.
Senator
Chairman,
Sproul.
we could talk about a bill that she can talk about administration. I just don't want to say, listen to badge administration.
I didn't.
So you talking about a bill, or you talking about badging administration?
No, I didn't. What I said was to address the concerns of the administration. And so,
I just want, for purposes, I have 2 bills in health and ed. I've gotten 3 hooks. I'm going to turn the committee over briefly to Senator Stewart, and he'll be running it. So, and I shall return. Okay.
Thank you, Mr. Chairman. In one of the concerns about the individual marketplace is not reducing the size anymore. There are about 350,000 covered lives in the individual marketplace. Some of those are covered by subsidy from the federal government. And some of those are covered by people paying out of their own pocket because they are not eligible to be in the small group marketplace or the large group marketplace. I want to make sure I just want to have everybody's attention because it's a little confusing. All right, you can do whatever you need to do.
Please,
So,
Senator
all right,
Donovan,
so
go
there
ahead.
are 3 insurance marketplaces in Virginia. One is the individual marketplace where we have the most expensive insurance products that we have and where the federal subsidy is and where the least competition is. That is where we have had we've gone down to 1 plan in certain regions and costs have escalated so much. The other insurance that we have in Virginia is small group that you can participate in if you have up to 200 employees. And the third is large group insurance, which is like the association health plan we just talked about. Large group insurance is the most cost-effective and the one that everybody would like to get into because it is so cost-effective. Why is it different? It's different because there are 4 pillars of every health plan, and for a large group insurance, instead of having that negotiated by a health plan itself with the profit margin built in, those 4 aspects of the health plan are negotiated separately. And therefore, there is inherent savings in the cost of the health plan itself. The second reason why the large group marketplace is doing better is that they're using large populations to determine where the risk is, where the greatest cost in healthcare dollars are, and they are designing clinical interventions to improve the health of individuals suffering with those illnesses. And as a result, they are reducing the cost of healthcare and improving population health more successfully than we are in other marketplaces. What's an example? An example is a group that realizes, like Michelin Tire in South Carolina, recognized that they had a large population of diabetes. You design a clinical management plan for your diabetics that includes a glucometer that as they check their blood sugar goes back to the case manager. They work with the individuals to make sure they stay compliant with their therapies, and the result is they have lower hemoglobin A1Cs, less hospitalizations, less amputations, less complications, and they cost less. So it is a way to achieve the goals better than we are able to do in other places where there is less engagement. What I propose is that we consider taking the entire individual marketplace, not dissecting it out, but taking all 350,000 individuals, creating a corporation under the SEC, and making that a large group marketplace. That would allow us to keep it all free market. Anthem would be able to compete to be one of the benefits providers. We could have oversight over our PBM, which is where the pharmacy costs are so high. We could save costs in health insurance, but we could also actually make some strides in improving population health for those in Virginia that are in the individual marketplace, and maybe even make it a more attractive marketplace for other people to participate in. So I know it's kind of radical, but we need radical. We are in trouble with healthcare right now in this country, and no other state has done this. I would like Virginia to look at proposing and doing something a little bit radical. I've talked with actuarials, I've talked with private sector that run these programs, and there is reasonable expectation that this will cost less than the individual marketplace costs now, just from the health insurance savings alone, with the opportunity to realize even more savings if we actually reduce the cost of health care. And for me as a physician, the idea that we are actually improving people's lives by improving their health is what I really am here to do.
Mr. Chairman,
Senator Sproul.
I really appreciate what she's trying to do, but it'd be really nice if she would get with the administration, number one, to run those ideas about administration, because there are some of us who do not agree with what you are saying, and some are. So I don't want to vote on an idea based on what you think, because some of it is good. But what about this part is not good? But it'll be nice if all concerned, you bring your ideas to those of us who think different. You bring your ideas, especially to the administration, who will have a staff who will sit down and say, hey, this part is good, what you're talking about. This part may not be good. But if you want me to vote on something because you say so, and because I support the administration, and he may not always be right, and I would tell him that, but still, it would be nice if you would take those ideas that you just got through saying and get with the administration, because those of us who work hard on trying to get insurance for all of Virginia, and that created the president of some of y'all up there who think different than what we think. But it'd be nice if we take those ideas to talk with the administration and those insurance companies and those who have some concerns and say, I think this idea is better.
Mr.
I hope
Chairman.
that you don't try to use us to vote for an idea because your idea without the administration having some input to it.
Mr. Chairman.
Senator Donovan.
Mr. Chairman and Senator Sproul, I indeed have been speaking with the administration. I have met with the Secretary of HHR. I've talked with the Board of Insurance. I've spoken with the governor himself and with his staff. And they are looking at this proposal. But I will submit, Mr. Chairman, that one of the ways we have a conversation with the administration is through legislative action. And I would like us to show support from the, and I will also mention, Mr. Chairman and Senator Sproul, I've been talking with Democrats in the Senate as well. This is not a Republican-Democrat conversation. This is a Virginia conversation. Can we put the effort in to innovate and do something different and save money for people who are paying and improve population health for those that are dependent upon us? And Mr. Chairman, I'd like to ask you to support this bill so we can continue the conversation.
Senator Donovan, I agree. And Senator Sproul, I would just say I appreciate your thoughtfulness on this, but there is a separation of powers doctrine, and so the legislative branch tends to look at what they think may be a good idea, and then they put it on for the executive branch to take a look at it, and hopefully we all work together. And I really hope the governor, who I find to be a very good man, will take a serious look at this so that we can make something like this happen, because what I'm finding, at least with the people that I know and represent, is that they can't afford health insurance. And we have got to come up with some bold ideas to help them. And I commend Senator Donovan. Do you have folks who'd like to speak in support?
I don't think I do, Mr. Chairman.
Anybody who wants to speak in opposition? Is there a motion on the bill? Motion properly, Senator Dance.
I know that we have somebody here from the that represents the governor's office, and I would like to hear that person weigh in because of the concerns that my colleague has as far as whether or not they've had a chance to look at this bill.
You certainly may hear from representative of administration.
Trying to give everyone a break. Mr. Chairman, members of the committee, we did meet with Senator Donovan yesterday to discuss the legislation. There are several concerns that we have with the legislation, and we're working with her to kind of get some responses. Right off, the first thing is that we don't know what impact this will have on the premiums. The bill removes and eliminates the subsidies that individuals receive through the individual marketplace to be able to afford health care. It withdraws Virginia from the federal marketplace, and it's unclear how individuals will purchase insurance moving forward. It also creates a new entity within a corporation. If you talk to the Bureau of Insurance, they have some concerns over what that will look like. Additionally, there's some solvency concerns that the Bureau of Insurance are also willing to talk to you about. So we have some concerns. We don't have a position, but it's something that we need to look into before we could provide a position. Thank you, Mr.
I
Chairman.
suspect you're going to get a chance to look into this.
Mr. Chairman?
Thank you.
Mr.
Senator
Chairman,
Dance.
since you mentioned the Bureau of Insurance, could they weigh in?
Senator Dance, if you would like to hear from someone as a member of this committee, you absolutely may ask them
Thank
to
you,
come
sir.
up.
I surely would like to hear from them since they're in this room. Speak now.
Don Beatty, Bureau of Insurance. On this, we have no position. However, we do note that there's a lack of funding in the proposal, and it would cost money not only to start up the company that's being asked to be created, but you also need funding to have the initial normal funding that you would have for an insurer. Before you make any sales, you have to start paying rent, paying employees, even though you haven't sold any policies. So we need that initial funding. There's a reference to a self-funding reserve. We don't know where the money would come from that if there's a shortfall. So we have issues with respect to how the operation would work, and then operational issues as to how it would fit into the commission structure overall.
Thank you, Mr. Chairman. And could I ask a question of the patron?
Absolutely.
Thank you.
Senator Dance.
Can you tell me whether or not we have a budget amendment in to address?
We do have a budget amendment in, but I will tell you that the way the bill is currently constructed, that there are bonds that are used for startup costs until the cost of the plan would be derived from the savings. This is a 1332 waiver application. We would spend a year figuring all of this out. These are all opportunities that you're hearing. Concerns or opportunities of how do we actually do something that's new. And I agree with all those concerns. The idea here is not that I have scripted exactly how this will be formed. The idea here is that conceptually, the most cost-effective insurance that we have is large group marketplace. And why are we not taking advantage if we're creating other groups like benefits consortiums? Why is the state not taking advantage of that? So this is conceptual with a year to figure out how to do the 1332. I do want to correct a couple of things. The subsidies would remain the same. There would still be a tiered subsidy for individuals in the marketplace between 100 and 400%. There would also be financial incentives for the patients to participate in the clinical programs, which is how large group marketplaces get engagement of the patients when they're working. In addition to that, there are financial incentives for people who are transitioning from Medicaid into this marketplace so that we take away some of the negatives of that slow climb to success when you might not make enough money or get employee-covered health insurance, but you still have the opportunity to make more money than qualifies you for Medicaid. So there's a lot of good stuff in here. It's not figured out yet, and that's exactly right. We all have to get together and figure out how to do it, but conceptually, we actually have something to offer. And what we're looking at with it, and this includes a state-based program, which the government alluded to, the governor's office alluded to, as well as not dissecting out the individual marketplace. This is a bipartisan innovation that Virginia can lead on so that we can make a difference for our citizens, and it's at least worth figuring out if we can do that over the next year.
Okay. I understand no one wishes to speak for or against the bill. I understand we have a motion duly seconded. Clerk, open the roll.
11 ayes, 4 nays.
All right, the bill's been reported 11-4. Senator Donovan, does that complete?
Yes, it does, and thank you for your patience.
Absolutely wonderful. Okay. Senator Carrico, Senator Howe. You had that doe-eyed look.
Thank you, Mr. Chairman. I have 1650.
All right.
This is a mandated benefit, and I know it needs to go to the commission.
Right.
But what it mandates is that donated human breast milk be provided for infants under 2 years old.
Okay. So we will pass this by indefinitely, and I will forward a copy of the bill with a letter. Staff's got that. To the Mandated Health Benefits Commission to ask that they look at it. So is there a motion to pass by indefinitely? It's been moved and seconded that the bill be passed by indefinitely. gently with a letter, understanding. Clerk, open the rolls.
I've never before thanked for a PBI, but thank you.
You are certainly welcome, Senator Howland. Thank you. Okay, Senator Chase. Senator Donovan is out of here. Senator Carrico, not around. Senator Peterson.
Mr. Chair, members of the committee, I have two bills. I think I'm going to start first with the vertically integrated carrier bill. That is Senate Bill 1402.
Okay.
And let me just describe what it does. First of all, this deals with let me describe what a vertically integrated carrier is. It's where a hospital system owns a health insurance company. So you have both a hospital, a health insurance company. So you have basically the same actor on both sides of the economic equation. And my position has been, and I've sort of had a lot of discussion with a lot of people in this building, that there's an inherent conflict of interest in that situation, that someone that owns a hospital and also owns an HMO would have the incentive to refer the business to themselves, or at least give preferential treatment to themselves. This has come up in the context in this bill of where you have a public hospital that, again, is trying to survive in a certain area. What my bill would do, and I draw specific attention to the language, is require the hospital to offer its products, and I'll draw your attention to the language. Require the vertically integrated carrier to offer its products. This is on line 152. Each vertically integrated carrier shall offer participation in each provider panel or network established for each of the vertically integrated carriers' policies, products, and plans. So this is what the HMO would have to offer. And in referring to the public hospital within its territory, be without any adverse tiering or other financial incentives that may discourage enrollees, in other words, patients, from utilizing the services of the public hospital, and include all services offered by the public hospital and any other entity owned or operated or controlled by the public hospital. The idea would be that basically if you're going to have someone that has an inherent conflict of interest and they have a public hospital within their carrier network, that they have to offer these services. Now, again, as to what the market price would be, as to what would be reasonable in that situation, my legislation does not micromanage that. I understand that obviously that would be the subject of negotiation. I also understand that at least one of the parties that is affected by this bill, there has been a contract entered, which is a short-term contract. I understand. I'm sure you're going to get more details about it. Basically, my bill is a statement of policy, and that is, again, where you have a vertically integrated carrier that where they have public hospitals within their network, that they have to treat those hospitals fairly and give those patients that service those hospitals or utilize those hospitals fair treatment. So that's the sum and substance of my bill. I know there's folks that would love to speak to it, and that's it.
Thank you, Senator Peterson. Okay, are there those that wish to speak in favor of the bill?
Senator, members of the committee, I'm Curtis Bird with Chesapeake Regional Healthcare. Thank you, Senator Peterson, for championing this policy initiative. This is really about having choice. This is about people having the ability to say they want to go to a public hospital. There are 4 in the Commonwealth of Virginia, and they should have the right to decide where they go for their health care, who they see to provide them with their health care. The problem is that you have a parent company that directs its insurance arm to limit where people in their that they cover can go. And so when you have choice, you have something that's called beneficial competition. And beneficial competition then leads to reducing the cost of health care. And so as an independent hospital that needs strong relationships with independent physicians, we seek to strike those relationships with them to create options in the community, in the market. That would be lower cost options, innovative relationships, so that people have a say in not only where they go, but in the kind of investment they're making in their health care. And so what I would suggest is that there's been a lot of misinformation put out there. I've heard myself that legislators have been told, you told us to fix this problem last year. This committee reported this bill out last year, and it passed the Senate. we've got a contract with Chesapeake Regional. We don't know why we're here. I mean, you told us to fix it. We signed a new contract with them. But the issue at hand is that they limit what services and locations that we offer to the community. So thank you. We ask that you support this.
Thank you. Other questions? Senator Stewart.
The gentleman who just testified, are you the only hospital that's impacted by this? Are there others that are impacted by it?
Well, it would apply to the state's 4 public hospitals. So it would also include UVA, Virginia Commonwealth, MCV, and then there's another public hospital down in Norfolk.
Are they in any way impacted? Because I've not heard from them. That's why I'm asking.
They don't have a position.
Are you the only hospital that's affected by this?
So our CEO is here
find out.
as well. So I think that, to the more specific questions, I think, he'd be happy to share some specifics with you.
It was just a simple, are you the only hospital who's affected by this at this time? That's all I'm trying to find out.
No, it would apply to all of the state's public hospitals.
Okay. Senator Stewart, complete your question. Okay. Yes, sir.
So I'm Reese Jackson. I'm the president and CEO of Chesapeake Regional, and I want to be here to answer any questions that you may have to deal with any ambiguities or misinformation. But I do want to just share that when a contract negotiation begins with a comment, this is what my parent company tells me I can and can't do, then right off the bat, that begins the opening salvo of limiting competition and limiting choice. So you can ask, this is not personal. I like the folks that work with Optima. I like the folks that work at Centera. It's not personal. This is just about an independent hospital, a state hospital, a public hospital, one that's a creature of this state statute. So we're here in earnest. We're not here because this is for fun. I don't want to be here. Okay? The other thing I would like to also say to you is that contracts have a finite term. Public policy should go on for a long time, hopefully forever. Okay, so there's a big difference between a contract, and I think folks have laid out the policy agenda very well. I would also just say that, can you imagine a scenario where Optum is selling insurance product on the exchange in Charlottesville and carving out UVA? I don't think you want that. So I think this does have some transcendent qualities to it, and I would like for you to consider those. But I'm around I'm available now if you have questions. I'm a very transparent person.
Are there questions? Seeing none. I think there's other speakers behind you, sir.
Thank you.
Are you in favor? Okay.
Oh, yes, thank you.
All right. I'm going to start the timer. All right. Those opposed?
Good morning, Mr. Chairman and members of the committee. My name is Mary Blunt, Senior Vice President with Centera Healthcare. Last year, I and Centera leadership met with many of you and heard your recommendations, and subsequently, we worked with Chesapeake Health on a resolution. You will hear more about that from Dennis Mathis, President of Optima Healthcare, which serves 500,000 members in the state of Virginia and 114 hospitals. Thank you.
Thank you.
Good morning, Mr. Chairman and members of the committee. I am Dennis Mathis. I'm president of Optima Healthcare. Optima is one of 111 providers-owned health plans across the U.S. that cover roughly 17.6 million people. So this is not a unique phenomenon in the state of Virginia. We oppose this bill due to the following facts. Since our inception in 1984, Chesapeake Regional has always been in the Optima network. And in fact, we just renewed with Chesapeake Regional a month ago for a new 4-year arrangement. Secondly, this bill is in direct conflict with industry trends and best practices for promoting quality and clinical outcomes for members of our communities and could increase the cost of care over time. This bill also sets bad precedent for government interference in private business negotiations to the disadvantage of a single organization. Out of a city population of 240,000 individuals, Optima Health covers 46,000 Chesapeake residents, almost 20%. We appreciate the need for those members to have ready access to their hometown hospital, and in fact, Chesapeake has never been out of network in the entire existence of Optima. Centera has a strong commitment to the Chesapeake community. In fact, Centera employs more individuals in Chesapeake than Chesapeake Regional Hospital. In line with legislators in Hampton Roads' request, we worked diligently with Chesapeake Regional over the past year to sign a new 4-year agreement starting this year. Specifically, Optima signed a 4-year contract 4 months early and issued a joint press release with the CEO of Chesapeake Regional, praising the professionalism of Optima's contracting team and assured residents of Chesapeake Regional's commitment to providing services to Optima members. Based on these events and acts taken in good faith, we believe this legislation is unnecessary. Secondly, the intent of this bill conflicts with industry trends and best practices for health plans promoting appropriate care and better clinical outcomes through network design and contract terms. We use network design to help make sure members are getting access to the most appropriate care and the highest quality. Pieces of this legislation would prohibit us from being able to do that, so it's in direct conflict with our mission of trying to provide quality care at the lowest possible price. Finally, this bill sets precedent for the General Assembly intervening in a private business contract term focused on a single payer and provider. So contrary to what you just heard, the bill does exclude VCU and Inova. Both have integrated delivery models. They are not subject to this bill, and so I would question the comment around this is policy, because if it was policy, it should be for all carriers in this state, not just directed at one. Also, by narrowing the definition of which health plan it applies, this bill puts Optima Health at a true disadvantage when others are not held to the same requirement. Again, if this is the right approach, why not extend this to Anthem and Aetna? I submit as an unnecessary and potentially harmful intrusion of state government into private business matters to the benefit of one hospital and the detriment of our 46,000 members in Chesapeake. We are committed to our 35-year relationship with Chesapeake Regional Healthcare. We will continue to work with them as we do all providers, but this bill is not the solution. Thank you for your time.
Thank you. Yes, sir. Briefly now.
Hello, Mr. Chairman, members of the committee. My name is Samuel Gerstmeyer, Director of Development and External Affairs for Centra Health and Piedmont Community Health Plan in Lynchburg, Virginia. So the question was asked earlier, does this affect other hospitals? It does affect other plans and our relationships with public hospitals. Piedmont Community Health Plan is a small plan in Central Virginia, fully owned by Centra Health since 2014. For roughly 20 years prior, the plan was a joint venture between Centra and a group of local physicians in the community. We only sell plans really in the greater Lynchburg region and in parts of Southside Virginia. We were hopeful last year that there would be a resolution to this issue that did not necessitate a statewide policy that would affect our plan and our contractual relationships as well. So ultimately what this bill does is it hampers our plan's ability to develop a cost-efficient, high-quality network. So our plan, even though we're vertically integrated, has to compete just like any other. And so this is not to say that our public institutions are not high quality. They are some of the most high-quality institutions in the state. But if you start mandating the contracting and the terms in those contracts, then you remove our plan's ability to appropriately get a fair price in the contract for our members. And so this bill, as policy, raises the prospect of increasing costs for tens of thousands of Virginians in the greater Lynchburg area. And so for that reason, we hope you do not endorse this policy and we oppose it. Thank you.
Thank you. Yes, sir.
Mr. Chairman, members of the committee, great to see you again. My name is Chris Feraldi. I'm representing the Lynchburg Regional Business Alliance, which is Regional Chamber of Commerce and Economic Development Office in the Lynchburg region. We oppose this legislation.
Thank you.
Mr. Chairman, Doug Gray on behalf of the Virginia Association of Health Plans. We don't think this bill is necessary. When you go down the road of getting involved in little contract disputes over and over again, it'll never end. And we don't really think it's an appropriate thing to get involved in.
Thank you. Yes, sir.
Mr. Chairman, members of the committee, Ross Snare, Prince William Chamber of Commerce, and we're opposed to the bill.
Okay, thank you. All right. I think we heard from both sides. Chap, you want to wrap up?
I do.
Okay.
Let me just give a brief rebuttal. First of all, if you look at the actual text of the bill, it just simply says that a vertically integrated carrier shall offer participation without any adverse tiering and including all services of the public hospital. So as to negotiating the actual terms, that's up to the parties, but it's just say they shall offer participation. Number two, I do have to laugh a little bit when I hear about this extolling of the free market, because when I cross the other side to Bank Street and sit in the health committee and I hear all the COPN debates, and suddenly I don't hear that. I think folks are on both sides of this free market issue, but the bottom line is, yes, I believe my bill would help competition. And the final thing I'll just simply say, Mr. Chair, is if so many lobbyists are against it, it's got to be a good idea.
Mr. Chairman? Mr. Chairman?
Yeah, Senator Sproul.
Mr. Chairman and members, hold a minute. I got to get my beads out. Thank you. Mr. Chairman and members, talk with Senator Cosgrove. He and I both live in Chesapeake. And John says to me, weigh it very carefully, Sproul. He said, you know, we live in Chesapeake. And he said, I'm going to leave my proxy vote yes. And he said, but weigh it very carefully because you represent Norfolk and Chesapeake, both hospitals. And then I say, now do I vote with the popularity as far as the lobbyists because of the political thing, or do I vote because it's the right thing to do? And knowing that Chesapeake General Hospital, Mr. Chairman and members who are here, it started from mothers and people in the community. We started by having bake sales to the hospital. We have commissioners appointed by City Council, and we started from scratch. We don't have any of the big boys like some of the big hospitals do. We don't have any big boys and big lobbyists. Chesapeake is a small hospital. They're just surviving because they are doing the right thing for their citizens. And then here, Mr. Chairman, I'm sitting here saying, Sproul, you got both of these hospitals in your district, and you got Anthem barking at one issue, and you got your friend Doug, who is my friend, and then you have, looking on the other side, you got the Norfolk Regional Hospital, and those are my friends. But Chesapeake General, that's what I'm going to call it, that's home for me. Where we did not have a hospital, we started. And this is the right thing what Senator Chap Peterson is doing. We are trying to survive, and we are doing good, and we are on our own. We call it ourselves the single hospitals that everybody's trying to take over or either trying to shut down. That's what we want. And I thought about this thing. Now I say to myself, I got to stay by home. This is the right thing to do, and I'm asking those of you who are on this desk, please make sure what Chap Peterson is saying, he is telling the truth. For one time, let's not make a political issue of this thing. This is the right thing to do for Chesapeake General Hospital, who represents so many who wants to stay to the hospital. You'd be surprised at those who have to come from North Carolina who has to come to Chesapeake General Hospital. Other places who come to our hospital because they need help because we are a good hospital. And we don't have some of the things that the big boys don't have, but we're trying to get there. And in order to get there, we need your help. I'm asking y'all, please support this. Thank you so much.
Got any beads left there? Senator Sproul, did you run through all the beads? Okay, I just want to make sure. Okay. All right, I think we've heard from all sides. Is there a motion on the bill?
Move to report.
Been moved and seconded that the bill be reported. Clerk, open the roll.
Nine ayes, 5 nays.
9 ayes, 5 nays. The bill is reported.
All righty. Mr. Chair, in keeping with that populist theme, my next bill involves the insurance industry for auto accidents, and it's the Senate Bill 1117. And this has to do what we call bad faith claims under uninsured and underinsured motorists, and I know Senator Obenshain and Senator Stewart are familiar with this practice. Let me give you an example just so I can make this real to somebody. I actually had and I won't say I had a case, but let's say there was a case last year where somebody is hit by a vehicle. They sustain serious injuries. There's, say, a $50,000 policy from the motorist that hit them. The person that was injured has their own UIM coverage, underinsured motorist coverage that adds another $50,000. So there's basically $100,000 at the table, and the damages, including hospital bills, everything else, is, let's say.
Okay, hang on a second, Senator Peterson. Is there anyone opposed to this bill?
I don't know. Usually is.
Oh, okay, keep going.
Okay, so Let's imagine.
Senator Obenshain had a wild thought that no one would oppose this. We could roll right through it, but no.
The bottom line is, let's say, for example, I have to go to trial against that motorist, and I get a judgment against him because, for whatever reason, the carriers did not put the money up. Even if the hospital bills exceed the coverage limit, even if he's out of work, even if I have undisputed damages, the carriers just don't put the money up. We go through discovery, we try the case, I get a judgment. Now I can go after the person that had that insurance policy. I can foreclose on his house. I can garnish his wages. I can do all those things. The question would be, what penalty do the insurance carriers have to step up and accept for not covering that claim? Now, I wish I could say that in all cases carriers step forward and cover claims, but there are situations where, for whatever reason, let's face it, it's an advantage for them to require you to file suit, wait a year and a half to get a trial date, and by the time you get to the courthouse steps, they may put the money out, they may not, but they have an incentive to not pay off right away. I get that. This bill holds their feet to the fire by doing a couple things. Basically, it sets a standard when there's a refusal or failure to pay, which is deemed unreasonable by the court. And again, I think that's something that we define reasonableness all the time in the law. And then secondly, you can have this adjudication done basically as a post-trial motion, which I think is important because otherwise you got to go and file a whole new case, bring in all the parties when you already have the insurance companies at the table. The UIM carrier would be a party at that point. So the bill is what it is. Again, it deals with bad faith, what we would consider a bad faith refusal to cover, and it would protect people.
Do you have anybody speak in favor of the bill?
You know what? I had some witnesses that couldn't make it today. I had a couple folks that brought this to my attention, but I speak also on my own behalf.
I understand. All right. Thanks, Senator Peterson. All right. Let's hear from the opposition.
Good morning, Mr. Chairman, members of the committee. Chris Legault for the American Property Casualty Insurance Association and Nationwide Insurance. I would note for the committee's historical reference, the identical bill was introduced last year and sent to this committee and re-referred from this committee to the courts committee, where it was carried over last year without action taken on it. We do oppose this bill. There's really no good reason for it, quite candidly. In 2015, extensive legislation was introduced and passed by this body addressing underinsurance claims. That legislation is certainly working and working well enough to where it's not a problem in the court system. This bill has a number of flaws to it, and I've got other people here to speak, but talking about a reasonable settlement demand, reasonable in whose eyes? Reasonable in the eyes of the plaintiff attorney. It could be declined for any number of perfectly bona fide good reasons. And any time that it is, this bill will say to the insurance company, now you have a cloud hanging over your head that a bad faith claim is going to be brought against you for reasonably declining to accept the settlement demand. So for all those reasons, we would urge you to not act favorably upon this bill or to re-refer it to the courts committee where it was last year.
Senator Peterson, apparently Nationwide is not on your side. Okay. And to give credit where credit is due, I was getting to that. Senator Saslaw put that bug in my ear. Yes, sir.
Mr. Chairman, members of the committee, Alan Kidd for Virginia Farm Bureau. I would echo Mr. Legault's thoughts. We oppose this bill.
Thank you.
Mr. Chairman, members of the committee, Jackie Stone on behalf of State Farm, and we oppose this bill.
Okay.
Thank you.
Mr. Chairman, members of the committee, Vicki Harris on behalf of State Farm, USAA, and we oppose this bill.
Okay.
And I will add to that, we are a heavily regulated industry. The Bureau of Insurance has the ability to look at our files, determine whether or not we are paying our claims and paying them in a reasonable fashion. They also have an opportunity to respond to individual consumer complaints about claim handling and look at a targeted file. So this is a solution in search of a problem.
Okay, thank you.
Thank you.
Good morning, Mr. Chairman, members of the committee. Kelly Suling with Geico, and we oppose this bill.
Apparently the gecko is going to bite you too, but okay. Is there anyone else? All right, where's Florence? Florence? Okay, she's not here. All right. Senator Peterson, would you like to wrap up?
Let me just preface my rebuttal by just saying even a caveman can understand that this is a good bill. I'd simply say that I don't anticipate that a ton of these claims will be made, but the bottom line is you have to have some incentive for insurance companies to do the right thing. There is a reasonableness standard. A trial court will make that determination. We put people on the circuit court bench to make a lot tougher calls than this. And so I think it's a good idea.
Okay. All right, it's been moved and seconded that the bill be reported. Clerk, open the rolls.
Eleven ayes, 4 nays.
Okay, 11 ayes, 4 nays. The bill reports. Okay, who's next? That would be Senator Chase.
Thank you, Mr. Chairman. Senate Bill 1228, I would actually request that it be rolled into Senator Sturdivant's Senate Bill 1763, also addressing balance billing.
Okay, we will. So, Chrissy or Frank, how does Senator Sturdivant's and my balance billing line up? Okay. Oh, boy. Okay. Okay, Senator Chase, okay. You requested that your bill be rolled into Senator Sturdivant's bill, and is there such a motion? It's been moved and seconded that bill be rolled in. Clerk, open the rolls.
Mr. Chairman.
Do we have the wrong bill up? What bill was that you wanted rolled in?
So I would request, Mr. Chairman, Senate Bill 1228 be rolled into Senate Bill 1763 and added as a chief co-patron.
You got it. Okay.
Thank
It's been
you.
moved and seconded those bills be rolled together. Clerk, open the roll. Okay, that one's off your docket now. Do you have another bill?
I
Senator
do.
Chase?
This is going to be quick too, Mr. Chairman. Senate Bill 1006. Mr. Chairman, I move to strike Senate Bill 1006 contingent upon you sending the agreed upon letter from Senate Commerce and Labor to the Virginia Bureau of Insurance. This is a bill having to do with buying and selling insurance across state lines. And this requests the Bureau to conduct a study in conjunction with my office in which Virginia health plans be provided an incentive to control premiums for health care insurance. I have a letter here which I'll give you, Mr. Chairman, but the study shall include the consideration of a tax rebate for health insurance companies which do not raise their annual premiums more than the CPI, and the Bureau must provide a report on these proceedings to the chairman of the Senate and House Commerce and Labor Committees prior to October 1st of 2019.
What's that?
I have letters.
You don't have Senate Bill 1228? First thing on the list. You got it? Okay. All right. We have a motion to strike and a letter. I will certainly look the letter over, Senator Chase, and commiserate with the Bureau of Insurance and ask that they include that. So, is there a second?
To strike?
Yeah.
Second.
Okay. It's been moved to second. The bill be stricken. Clerk, open the roll. Okay.
Thank you.
I believe you're done, Senator Chase. Okay. Senator Carrico, Senator Barker, Senator Locke, Senator Ruff.
Thank you, Mr. Chairman. Senate Bill 1161.
Senate Bill 1161.
And I believe there are a couple of technical amendments that need to be adopted. You don't have them?
Okay. Will clerk report to you? Oh, you were handing them to the clerk.
Mr. Chairman, for every household in which cancer is part of the diagnosis from the doctor, it's like getting hit in the head by a 2x4. Just the word cancer changes the lives of the family. This legislation is to address the time frame when a doctor believes it is proper to follow up with getting additional information from further tests and insurance companies' approval for these tests. This deals only with cancer issues to determine how aggressive the cancer is advancing. It allows for faster action when the medical provider determines the cancer to be of the nature that would endanger the patient's well-being. Frequently, with certain aggressive types of cancer, money can be saved when the cancer is dealt with early enough.
Just to start. The Bureau of Insurance amendments they recommended to you involve another code section, 2 sections, which would mean we'd have to prepare a substitute, which isn't being prepared. So what we will do is hear the bill, okay? And it's pretty clear we're going to have something at my desk anyway. And so do you have people in support of the bill? Do you have people opposed to the bill? Okay, come on up.
Brian Donahue with the American Cancer Society Cancer Action Network. We support the bill. What our friends in the insurance area are going to say is these processes are already in place, but that's not the right question. The right question is, are these processes robust enough and resourced enough to give these critical answers on a timely basis? And what I'm hearing from my patient navigators at the hospital, this is not the case. That's why we need this bill. Thank you.
Okay. Are there those opposed to the bill? Mr. Gray.
So, Mr. Chairman, this deals with external review. It does not deal with the health plan. And what the external review process already permits is if you have a disease of any kind, including cancer, in which the decision is urgent and needs to be done right away, you can skip straight to an expedited appeal. That's already in the statute today. So this doesn't really change a whole lot. What it does change is it's doing it by having a particular disease. So if you have cancer, you can skip to the end. It's not that you're in imminent danger and it has to be done quickly because of your health condition. So the statute's written on the status of your health condition. This is just written on whether you have a particular disease. So the practical impact is it'll just increase the number of cases that the Bureau has to process and go through. They hire an external review organization to do this, and their decision stands. We don't have anything to do with it. I just want you to understand you're changing from something that's based on the condition needing an expedited answer to just a particular diagnosis, regardless of how urgent it is. So
are you opposed or
well,
just informative today?
I'm just trying to make sure you understand. I mean, the statute really already permits it. And I mean, so I mean, if they think it's urgent, they can go straight to it. So,
okay.
I mean, you know.
So Senator Stewart moves the report. Is there a second? Been moved and seconded. The bill be reported. Clerk, open the roll. Thank you, Senator Norman. Okay, we have run out of, I'll run the list. Carrico, Barker, Locke. Somebody put a hook on them. Okay, we're down to committee members. And I believe I'm the committee member. Okay, all right, Rosalind, let's hear what you got. 1197.
Okay, Mr. Chairman, this comes at the request of the State Corporation Commission, Bureau of Insurance. The bill amends the Pharmacy Freedom of Choice section of the Code of Virginia. This code section gives an individual the right to select the pharmacy of his choice to receive his health insurance prescription benefits, including a pharmacy that does not participate in the insurer's network, if the pharmacy agrees to accept reimbursement at the in-network rate. The Bureau of Insurance realizes that insurance companies offering exclusive provider organization policies are not subject to the Pharmacy Freedom of Choice provisions and believes that the failure to include the exclusive provider policies was an oversight when the Pharmacy Freedom of Choice provisions were enacted. Thus, this bill will correct that oversight and make the Pharmacy Freedom of Choice provisions applicable to all managed care products and allow for even greater freedom for consumers to choose their pharmacy provider. The Bureau of Insurance shared the provisions of the bill with interested parties back in the fall, and there is no known opposition to the bill, Mr. Chair.
Okay. All righty. Does the committee understand the bill? Is there any opposition to the bill?
None known.
All right. Committee operates by motion. Been moved and seconded. The bill be reported. Clerk, open the roll.
$14 ayes, 1 nay.
Okay, thank you.
Thank you.
Senator Carrico.
Aye.
Aye. Understand we have a motion we'll all love.
Yes, Mr. Chairman, having spoken with the attorneys and been working with Norfolk Southern on this issue that we have experienced many, many times in Southwest Virginia when we're crossing the railroad in order to expand broadband to regions where there's sparse homes, but we get grants for those, and trying to alleviate eating up the grant funding by crossing the railroad with one strand of fiber, aerial or underground. It's been a very complicated process. So in this introduction of the bill, we've been able to get them to the table. We have a letter now from Norfolk Southern, and I know CSX and Shortline are mentioned in that, but they have all agreed that we can work this out over the year. I just would ask that the chairman strike the bill, but be mindful that we want to keep these negotiation realms going, because this, if we're going to get this to all the homes throughout rural Virginia, we got to have cooperation between the railroads without it being exorbitant in cost to get there.
Understand. Okay. We have a request from the patron to strike the bill. It's been moved and seconded that the bill be stricken from the calendar. Clerk, open the roll. Okay.
13 ayes, 1 nay.
That bill. Thank you, Senator
Thank
Carrico. Thank you. Senator Barker. Your target of opportunity.
That's right.
Okay.
Mr. Chair, I think I'll try to get this done within 2 minutes.
We like that.
And that's two bills. The first one is on...
a minute a bill?
Yeah.
2 minutes total or 2 minutes?
2 minutes total.
Okay, got it. Fire away.
First one is Senate Bill 1624, surgical assistance. We've made progress on this issue and now have them being more recognized. Things are going well with surgical assistance. There is an issue relating to reimbursement in certain situations. And what I would ask is that this bill be referred to the HERC.
Okay. It's been moved and seconded that this bill be referred. Actually, the motion, I think, would be to pass by indefinitely.
Yes.
With a letter to refer this bill to HERC.
That's fine.
Is that the motion I heard and seconded? Okay. Clerk, open the rolls.
15 ayes, 0 nays.
Okay, 42 seconds left, Senator Barker.
All right. Yes. The other is Senate Bill 1287. You guys have to vote faster next time. But,
No, that's all right.
Senate Bill 1287.
We'll give you another minute or two. Okay.
But deals with health insurance and making sure that there's not discrimination on the basis of gender identity or transgender status. There are clearly some issues here. This needs to be addressed. I don't think this legislation is going to go forward today, and I'll address that in a minute.
Okay.
But there are clearly some stories that sort of illustrate the problem, and I want to have one person to speak briefly to this
Sure.
and provide that. So.
Yes, ma'am.
Hello, pardon my voice, but the weather has been playing a little bit with my voice.
Sounds
my
just like
allergies.
my wife's. Okay, I understand. Go on.
Thank you. I am Rebecca Barrick. I'm a transgender woman, and I am a constituent of Senator Spruill. And I rise in support of this bill. Transgender treatment is safe and effective and necessary for many people. However, one issue that I face is that my insurer still lists me as a man named Rebecca. The reason for this being that if I were to change this, as I move along in years, I would not qualify for prostate health services. The problem being that since I'm listed as a man and not as a woman, I would not necessarily qualify for breast health services if I need that. Also, as I move along in years. And this is a very good bill. It basically says that termination must be made based on medical necessity, not on whether or not it fits whatever gender you place someone in a database. And for that reason, I, as well as many transgender Virginians, as far as I know, strongly support this bill and urge you to make favorable determination. Thank you.
Thank you.
All right,
Senator Barker.
we've had conversations with the Virginia Association of Health Plans. I think they understand better some of the issues that are being faced, and they're willing to work with us on things over the year. So with that, I would ask that this bill be stricken, and we will work with them and hopefully resolve this issue during the year. Hopefully may not even need to.
Thank you, Senator Barker. All right, is there a motion to strike? Moved and seconded that the bill be stricken from the docket. Clerk, open the roll.
Thirteen ayes, 1 nay.
Okay, that bill's been stricken. Thank you,
very
Senator
much.
Barker. Senator Locke.
Mr. Chairman, I have Senate Bill 1132,
Okay, committee, pay attention. Senate Bill 1132.
and this is the Reproductive Health Equity Act, which would guarantee that all Virginians get
Is there a
insurance.
substitute?
Yes, there is.
Appears there is. Okay, so motion on a substitute. Been moved and seconded that amendment nature substitute to 1132 be adopted. All those in favor say aye. Any opposed? Okay, the bill's before us. Senator Locke.
Thank you, Mr. Chairman. This substitute is the Reproductive Health Equity Act, which guarantees that all Virginians can get insurance that covers a full range of basic health care, including contraception, abortion, prenatal care, childbirth, and postpartum care. Every Virginian should have access to the full range of reproductive health care, starting before they ever become pregnant and going through childbirth. What Senate Bill 1132 does, this is an important step in filling the gaps in current policies so that each of us can be covered for our health needs without excluding anyone because of how much they earn, who they are, or where they come from. Restrictions on health care have the greatest impact on low-income people, people of color, immigrants, and survivors of domestic violence. This proposal will ensure every Virginian has access to reproductive health care. This bill ensures that everyone in Virginia can get insurance coverage for reproductive health care, and it is an important part of ensuring that everyone will have equal economic opportunities. This is also about ensuring that Virginians are healthy and that their babies are healthy. An ounce of prevention is worth a pound of cure. It's a lot smarter to cover birth control than to have unwanted pregnancies. And it's smarter to cover prenatal care than to take care of sick babies. When people can plan if and when to have children, it's good for them and for the whole society. So basically, this expands coverage for reproductive health care in the Commonwealth.
Okay, thank you, Senator Locke. Are there questions for the patron? Okay, do you have folks to speak in favor of the bill, Senator Locke?
Yes.
Okay.
Good morning, members of the committee. My name is Sarah Flores Shannon. I'm a field coordinator with the Virginia Latina Advocacy Network. I'm also a constituent of Senator Saslaw. One important aspect of the bill when we think of a full spectrum of reproductive health care is cervical cancer screenings. The incidence of cervical cancer for Latinas in the United States is among the highest out of any ethnic or racial group. Latinas face these high mortality rates for cervical cancer because of the low rates of cervical cancer screenings. It's really important to understand that cervical cancer is treatable and preventable, but sadly about 85% of women who die from cervical cancer never had a pap smear. Because of this, legal barriers to public and affordable health care coverage make a bad situation worse for immigrant women and their families. The Reproductive Health Equity Act is an important step in filling the gaps in our current policies so each of us can be covered for our health needs without excluding anyone. I also have a second testimony for one of our activists who was unable to join. She is a 19-year-old student at Northern Virginia Community College. She only recently was able to start using birth control to manage 5 years of chronic pain that she's been having due to her reproductive health care system. Because she is undocumented, seeking proper health care, reproductive or otherwise, has been very scary for her. And so she believes that the current healthcare system is not easy to navigate for low-income women and women of color. With this bill, we can at least facilitate the process of accessing these services by guaranteeing that reproductive health care will be available for all Virginians. Please vote in favor of SB 1132. Thank you.
Yes, ma'am.
Hi, my name is Chelsea Yu. I'm an activist with the Virginia Latina Advocacy Network. Throughout my life, I've been fortunate enough to have easy and affordable access to birth control, STD testing, pap smears, HPV shots, and cancer screenings. Because of this bill, everyone, regardless of who they are, where they come from, and what they make, can have access to a full range of basic health care services. Watching my friends struggle to attain these basic medical services has been very difficult. It shouldn't be this hard to have preventative health care options. I urge you to vote in favor of this bill so that everyone can obtain a full spectrum of reproductive health care.
Thank you. Yes, ma'am.
Mr. Chairman, members of the committee, thank you for your time. My name is Maria Ortiz. I'm with the Virginia Latina Advocacy Network. Recently, my mother had to go through a number of breast cancer screenings, and that ended up costing our family over $1,500 because she does not have health insurance. And as you know, many members of our community face obstacles to achieving affordable health as a result of barriers like poverty and lack of insurance. This bill will allow families like mine to not have to decide whether to put food on the table or to get a regular checkup. I urge you to support this bill. Thank you.
Thank you.
Good morning. My name is Sarah. I'm from Norfolk, Virginia, and I support this bill. Thank you.
Thank you. Yes, ma'am.
Good morning. My name is Julie Turner, and I am from Richmond, Virginia, and I support this bill.
Okay. Thank you.
Hey, my name is Autumn Clemis. I live in Richmond, Virginia, and I strongly support this bill. Thank you.
Thank you.
Good morning. My name is Sarah Florence. I live in Alexandria, Virginia. I'm a constituent of Senator Sasla, and I support this bill.
Thank you.
Good morning. My name is Carlota Arias, and I am a field coordinator with the Virginia Latina Advocacy Network. Last year, I decided to become a mother, and unexpectedly, I had twins. After having twins, I immediately knew that I wanted to have a tubal ligation surgery because this decision would allow me and my husband to take control of family planning. I had this surgery 2 months ago that would allow me and my family to have many economic opportunities to grow and flourish for years to come. I feel empowered that I chose this procedure, and I'm grateful that my insurance plan was able to cover the cost. All families in Virginia must have access to this voluntary service without facing barriers such as their immigration status or their lack of financial resources. These factors should not hinder anyone's personal or economic development. I'm here today to ask you to vote in favor of the Reproductive Equity Health Act so that every Virginian, regardless of their income or country of origin, can lead a dignified life where we are all trusted to make the best decisions for our own lives. Thank you.
Thank you. Yes, ma'am.
Good morning. Tanisha White, resident of Richmond City and with NARAL Purchase Virginia, and I support this bill.
Thank you.
Good morning. My name is Michelle Wooten. I'm from Newport News, Virginia, and I support this bill, and I hope you do as well.
Thank you so much. And yes, ma'am.
Good morning. My name is Casey Chavez from Fairfax, Virginia. I please ask you to support this bill.
Thank you. All right, opposition.
Mr. Chairman, members of the committee, Felicia Preissner with the Virginia Catholic Conference. We oppose this bill. It mandates the coverage and private health plans in Virginia to provide certain abortions, contraceptive drugs, voluntary sterilizations, and abortifacients. Furthermore, the bill's four-pronged religious employer exemption only applies to abortions and is unconstitutionally narrow. Most religiously affiliated organizations purchasing Commonwealth-regulated health benefit plans will not qualify under the definition of religious employer in this bill, including any charity that serves poor, elderly, and does not serve only those of their own religion. Hobby Lobby, Little Sisters of the Poor, and even Mother Teresa would not have qualified under this religious employer exemption contained within this bill. Additionally, the bill has no exemption or accommodation whatsoever for employers or nonprofits or religious employers that refuse to offer certain contraceptive coverage because of their sincerely held religious or moral beliefs. Furthermore, the bill also violates the Virginia's Religious Freedom Restoration Act by substantially burdening the free exercise of religion of those employers who hold sincere moral beliefs. By requiring the coverage of abortions by all Commonwealth-regulated health benefit plans, the bill also violates the Weldon Amendment. The Weldon Amendment provides that states receiving federal funds may not discriminate against health plans based on their decision not to cover or pay for abortions. The citizens of the Commonwealth should not be forced to violate their sincerely held religious and moral beliefs as employers by having to provide such coverage. Thank you.
Thank you. Yes, ma'am.
Good morning, Mr. Chairman, members of the committee. I'm Amy McInerney from Prince William County. I oppose this bill because freedom of conscience is a core Virginia value. In 1792, in his essay on property, James Madison wrote, quote, "Conscience is the most sacred of all property." A few years later, in 1809, Thomas Jefferson, whose statue in the hallway proudly proclaims him the architect of liberty, wrote that no provision in our Constitution ought to be dearer than that which protects the rights of conscience against the enterprise of civil authority. This opposition does not keep any person who wants or needs contraception from obtaining it. Rather, it protects citizens who, because of their deeply held beliefs, choose not to participate in or pay for these things through their health plans. This bill is actually anti-choice because it disrespects the conscience rights of Virginia women of faith or no faith who see abortion for what it is, the ending of an innocent human life. Government should respect our moral and religious objections. It should respect our rights under the First Amendment and the Religious Freedom Restoration Act. We should not be forced to pay for or participate in abortion through our private health care. Thank you.
Thank you. Yes, ma'am.
Hi, Mr. Chairman, members of the committee. My name is Therese Burnpool, and I am from Arlington, Virginia, and thank you for allowing me to oppose this bill. In a society striving to be so pluralistic, so inclusive, so diverse, how is it that we would force religious sisters, such as the Little Sisters of the Poor, force them to pay for contraception, sterilizations, and abortions? Little Sisters who actually work in Virginia and serves this very population. But in taking this a step further, why should anyone be forced to violate her or his conscience in this way? If we think that limiting people's freedom is good policy, we need to think again. If the state can take away my right to follow my conscience, it can take away yours. I'm not asking you to accept my beliefs, but to respect my rights to upheld them. And that is why I oppose SB 1132. Thank you so much.
Thank you, ma'am. And please be brief.
Mr. Chairman and members of the committee, my name is Monica Darnell, and I'm from Arlington, Virginia. This bill intrudes on my personal beliefs, and it frightens me that the government is continuing to force laws that mandate abortion, contraception, and sterilization. Abortion, contraception, and sterilization are not health care. I strongly oppose this bill.
Thank you so much. Yes, sir.
Mr. Chairman, subcommittee members, my name is Josh Hetzer on behalf of the Family Foundation, and we also oppose the bill.
All right, thank you. Are there any others? Mr. Gray? Yes. You've annoyed me already today, so I figured I'd return the favor, okay? I'm looking at 201 in the substitute. It said the plan shall not infringe upon an enrollee's choice of contraceptive. I got that part. And may not require pre-authorization. The plan cannot require pre-authorization, step therapy, or other utilization control techniques for medically appropriate covered. Are you aware of any other place in the code where we outlaw step therapy and the things that you use to control costs? Okay. Were you aware of that provision in this bill?
No.
Okay. And generally speaking, your plans have not supported this type of action.
We haven't.
Okay. All right, Senator Locke, would you like to wrap up?
Mr. Chairman, the Reproductive Health Equity Act basically levels the playing field. It's not our place to make important life decisions for someone else. When Medicaid covers the costs of all pregnancy care, including abortion, it means people can better make decisions based on what is best for their circumstances. People should be able to make decisions about abortion with dignity and respect and without politicians interfering, and a majority of Americans agree. And where we talk about conscience, conscience works on both ways, not just on one side of the equation.
Okay, thank you. All right, committee
Chairman?
operates. Yes, Senator Sproul.
I want to echo what Senator Locke is saying, that I do support this bill. Some of you may not be aware of that when you have some people saying religious beliefs, and I will stand to tell you everybody here is not Catholic, I'm not. But take my family for example. we believe in having babies, for example. I got 16 brothers and sisters. That was my mother's choice, bless her heart. I got 17 nieces and nephews. But nieces and nephews, they are having babies based on their need, whether they can afford to. They are deciding based on their spouse and the doctor, and they decide. So we can't have a religious belief, whether it's what I believe, what you believe in, to infringe on the family's rights, because my religion cannot afford to take care of your family. You know what you need. You know what's best for your family. So what Senator Locke is doing, we're trying to put safe measures in that these things can be done safely. We're trying to say, hey, let the doctors, let you and your doctor and family and y'all decide. That's what we're trying to do. We can't keep on letting folks come for us and say what their religious be. I could care less what my religion says. I'm saying what my family believes. And I love the Lord. I read it every day. But I know when I go home, what's best for my family? What can I afford to do? Can we afford to do this? What is best for us? And that's what Senator Locke is trying to say here. And sometimes we got to stop trying to force other things on people's families. Let them make the decision and not try to force my religion on what somebody should do. Please support this. Thank you so much.
Committee operates by motion. The appropriate motion would be to move, report, and re-refer to finance. It's been moved and seconded that the bill be reported and re-referred to Committee on Finance. Clerk, open the roll. Okay. Bill fails pass.
Not the least bit surprised.
4 ayes, 10 nays.
Thank you, Senator Locke. Okay, let's get the patrons on the committee. Senator Black is not here. Senator Saslaw. Sure, that's fine. What do you got?
This is, Mr. Chairman, members of the committee, this is Senate Bill 1266, and it deals with the open-end credit plans. Just requires that any person engaged in the business of extending credit under open-end credit plan in which the interest is charged at an annual rate that exceeds 36% is obtain a license from the State Corporation Commission to do so. It requires, a $50,000 bond on each location up to a maximum of $500,000. They can't sell this if they're in the same facility as selling car title loans or payday loans.
Okay.
And the borrower, if they loan more than $500, the borrower is not essentially obligated for that, and it prevents them from getting authorization to electronically debit from a borrower's deposit account.
Okay.
It deals also makes a prohibited practice under the Virginia Consumer Protection Act to violate the requirements applicable to extending the credit under the credit plan. Essentially, it's a licensing bill for people who are doing business in this state.
All right, thank you. I appreciate it. Is there those that wish to speak in favor of the bill? Very briefly. Yes, ma'am. Yes.
Mr. Chairman, members of the committee, Dana Wiggins with the Virginia Poverty Law Center. We appreciate the senator for bringing this bill, and we believe that it is a common sense measure. It just essentially puts similar restrictions that are on payday and car title lenders on another set of lenders that charge similar prices, and we hope you'll support the bill.
Thank you so much. Okay. Briefly.
Sure. Mr. Chairman, members of the committee, Dave Irvin. I'm with the Attorney General's Consumer Protection Section. We support the bill. The open-end credit plan statute has existed since the late 1960s. The problem is it has been used since the year 2004 to make largely unregulated loans and high interest rate loans to consumers. The statute, we believe, remains an outlier in our Virginia public policy. It remains an outlier in our consumer finance laws, and the result is an inconsistent public policy. With these laws, there is no licensing requirement, there is no SEC oversight, there is no limit on the interest rates that can be charged. We routinely see interest rates of 180% to 360%. We've seen interest rates as high as 960% on these loans. This is different from the regulation of any other lenders that we have in Virginia who make loans to borrowers of last resorts. We have limitations on consumer finance companies on their interest rates, at least with loans of less than $2,500. We have interest rate limits on payday lenders. We have interest rate limits on motor vehicle title lenders. We have interest rate limits on pawnbrokers. This is the only outlier, the only different area. Although this bill is not perfect, we certainly think that it takes a meaningful first step in terms of regulating this product, and we urge you to support the bill. Thank you.
Thank you very much. Are there those opposed to the bill?
Mr. Chairman, members of
docs?
the committee, Scott Johnson on behalf of Community Loans of America.
I
would ask you.
I thought the doctors had an objection.
They may.
We'll hear from you later. Okay. All right.
On line 35, our concern in this bill is today my client operates car title lenders that's regulated and operates open-end credit out of the same store as permitted by the law and complied with that. The effect of that line on line 35 is you could no longer operate those out of the same building. And so you're putting them roughly 55 to 60 stores out of business. And think about it. A borrower comes in today. If they've got a car that's got a lien on it, they're not going to be eligible for a title loan. So the only alternative to them is an open-end loan. And so for that reason, we respectfully ask that the bill not go forward.
All right. Thank you.
Mr. Chairman, members of the committee, my name is Robert Barada, and I'm here today on behalf of Check into Cash, which is a brick-and-mortar lender. We have many problems with this bill, but most importantly, of its treatment, unusual treatment of a regulated industry. It places it appropriately at the Bureau of Financial Institutions, but then it requires us to post a bond in each and every store and gives anybody who gets a loan through us a private right of action against those bonds. And then furthermore, after we're a regulated industry, it also makes us subject to the Virginia Consumer Protection Act, which is not done with other regulated industries over at the State Corporation Commission. Finally, I direct your attention to the second enactment clause, which says that there is a fiscal impact on this because it does subject us to the Virginia Consumer
I do have a
Protection
note that if we report this, the appropriate motion be refer to finance. So,
So we'd hope that you would not advance the bill. Thank you.
okay. Is there any questions for the patron?
Mr. Chairman.
Senator Sasslaw, I'd like to wrap
Just
up.
a quick comment. I think Scott came to me several years ago when I had this bill to bar car title loans and these open-end credit loans being given from the same facility. I think you asked me to withdraw that bill on the promise that this action would not occur, and I withdrew the bill.
Mr. Chairman, Senator Sasslaw, I think you're referring to consumer finance license. And you're right on consumer finance license. The bill was withdrawn, and my client's not making consumer finance loans out of these stores.
Senator Sasslaw, it wouldn't be the first time there's schizophrenia around here. I do have an amendment recommended.
The net effect is essentially dealing with the same type of people for not much difference in the end result.
Okay, I do have a technical amendment on line 269. Strike is 0 and replace it with cannot be determined. Is there a motion on that amendment?
Move it.
Been moved and seconded that amendment be adopted. All those in favor say aye. Any opposed? Okay, we have a motion on the floor to report and re-refer to finance. It's been duly seconded. Clerk, open the roll.
Five ayes, 10 nays.
Okay, bill fails to report. Senator Chafin, you have a couple of bills. Just let everybody know we're going to stay here right to the 11th hour. Okay, we're going to try to clean this docket off. The alternative is Friday. And I've been told by members of this committee that Friday's not an option. So yes, Senator Chafin,
yes,
please.
Yes, sir, Mr. Chairman. So there are actually two two bills here, Senate Bill 1222 and Senate Bill 1747, and I believe that there's a substitute that rolls the two bills together.
I'm going to leave you my proxy. I need to get back.
Like mine, but yeah, I know. Okay. Patient groups, not the people getting screwed. Not that patients. The patients getting screwed. Yeah, they like mine because it gives them information. Doesn't he ask? I guess. Yeah. Okay. All right. There's a motion on the substitute.
So moved.
Been moved and seconded to substitute to 1222 or 1747 be adopted. All those in favor say aye. Any
Aye.
opposed? Okay. Substitute.
So, Mr. Chairman, the bill that...
excuse me. Back to vote up. We now have to roll 1747 into Senate Bill 1222. Okay, is there a motion on that?
So move.
Been moved and seconded. Those two bills be rolled together. Clerk, open the rolls. Okay.
I can't vote. Yeah.
Okay. We now have everybody on the right page.
Yep. 15 ayes, 0 nays.
Okay.
So, Mr. Chairman, these bills, the rolled together bills, come at the request of the SCC Bureau of Insurance. Basically, the Bureau is recommending the renewal of producer licenses on a biennial basis, and also the fingerprinting of new producers to achieve greater uniformity of in producer licensing standards across the states. So it does allow the licenses to be renewed biennially. It coordinates continuing education due dates with their license renewal dates, which makes a lot of sense. It allows the implementation of the fingerprinting program. It also slightly modifies the makeup of the continuing education board and makes several changes that are technical changes.
Okay. Are there questions for the patron? Is there anyone opposed to this bill? Seeing none, committee operates by motion.
Move approval.
Been moved and seconded that the bill be reported. Clerk, open the rolls. Okay. Does that complete your docket?
15 ayes, 0 nays.
Okay. All right.
Thank you.
Bills are reported. Thank you. Senator McDougal. Gone. Senator Sturdivant. Yeah.
Mr. Chairman, members of the committee, first bill I have in front of you is Senate Bill 1027. This is the catastrophic health insurance plan bill that this committee heard last year, passed unanimously out of the Senate, and eventually was sent to the governor and was vetoed ultimately. But this is a bill that will take the catastrophic health insurance plans that are already offered under the ACA, but they are now restricted to those who are 30 years old or under, and we will submit a state innovation waiver to be able to expand the offering of these catastrophic health insurance plans to anyone in Virginia in the individual marketplace. These are again, ACA-approved plans, so they already provide preventive care and other things, but these are basically high-deductible plans for folks who, based on their particular situation and that of their family, may not want the bronze, silver, gold, platinum plans, but still want to have some level of coverage, and this will provide that to them. And now that we no longer have the individual mandate, we are oftentimes having folks just leaving the market altogether. This is a way to help bring them back into the market, have some level of coverage at a lower cost, higher deductible plan, so that we're offering more options.
Thank you, Senator Sturdivant. You're going to just eliminate age discrimination, request the
That's
federal
right.
government to allow us to do away with age discrimination and help us old people out a little bit. Huh?
That's right.
Okay. Senator Stewart, did you have a motion?
Mr. Chairman, I move the bill be reported.
Been moved and seconded the bill be reported. Clerk, open the rolls. It did pass here unanimously last year.
Can you vote me, Bill? Thanks.
Okay, Senator Sturdivant, you have another one.
I do. Next bill is 1178. Last year, we passed legislation that was signed into law that allows nurse practitioners the ability to practice autonomously under certain circumstances. The challenge is that we now need to authorize, give them the ability to be able to bill insurance companies under their own national provider identification number, so that they do not have to continue to do that billing through a physician. So now that they have that autonomy, we need to clean up the code a little bit so that they can bill and get paid on their own.
Okay. I think we understand the bill. Are there anybody, line amendment? Clerk, staff, if you'd report the line amendment.
Mr. Chairman, there are two amendments on after line 56 of the bill. Add a second enactment clause that says, two, that the requirements of section 30-343 of the Code of Virginia regarding the conduct of an assessment by the Health Insurance Reform Commission shall not apply to this act. And then the third enactment says, three, that the provisions of the first enactment of this act shall become effective on October 1, 2019.
Okay. Is there a motion on that amendment?
So moved.
It's been moved and seconded that the amendment be adopted. All those in favor say aye.
Aye.
Any opposed? Okay. Bill's before us. I think we understand the bill. Did we have a similar bill last year?
I don't believe so.
Okay.
No.
Is there anyone opposed to the bill? Seeing none.
Move to
Okay,
report.
it's been moved and seconded. The bill be reported. Clerk, open the roll. Okay. All right, next.
Last bill, Mr. Chairman, for which there is no controversy, and I think this is a total peace in the valley, is the my balanced billing bill. This is Senate Bill 1763. I know that there is a substitute, Mr. Chairman, that I would move.
Okay, is there a motion on a substitute?
Second.
It's been moved and seconded that the substitute be adopted. All those in favor say aye.
Aye.
Okay.
Mr. Chairman, every one of us probably has had constituents call our Senate offices. These are individual patients who have gotten emergency medical care and then only to find out later that the doctor assigned to them at the hospital was not covered by their insurance through no fault of their own, and they end up getting hit with a huge bill. The industry calls this surprise billing or balance billing, where the insurance company will pay the out-of-network doctor the in-network rates, and then the patient ends up getting this surprise bill for an enormous amount of money. And my office has worked many times with many constituents to try to help negotiate these bills. I brought a bill last year to have a study of this balance billing issue. I'm bringing this bill this year to prohibit balance billing outright. I know that there are a lot of stakeholders and folks who are involved in this, whether they be the insurance companies, the hospitals, the physicians, or the patients. My focus it has been strictly on how do we best protect the patients. I recognize that all those other stakeholders need to work things out, and folks got to get paid, and they got to get paid fairly. But the focus of my bill, the focus of carrying this legislation, is to prohibit the balance billing.
Well, Senator Sturgeon, but I don't see anybody going broke in the healthcare business. But
patients are, and that's right.
And that's the only group I see going broke, and I couldn't agree more. I have a similar bill. I had asked staff if you could report the differences between the legislation that I'm carrying regarding emergency room balance billing and what Senator Sturtevant's carrying. Can you pin it down for us?
Thank you, Mr. Chairman. And I know there's some people in the room who may be more familiar and better able to point out the differences. But just briefly, Senator Sturtevant's bill offers a regional average for commercial payments that is not in your bill. Senator Sturtevant's bill also addresses the fair market value, which I don't believe is addressed in your bill. It's a different way of determining basically the out-of-network costs that the insurance company will be on the hook for.
Okay, and I think I did a percentage of Medicare if I did not, as a trying to determine it. And I know Senator Obenshain is going to ask the question. Senator Obenshain, ask your question.
Who determines fair market value? Is that the hospitals?
The Bureau of Insurance that determines that? Bureau of Insurance, right? Yeah.
Mr. Chairman, Senator Obenshain, fair market value is determined essentially it's a negotiation between the provider and the plan. It's an agreed to amount. And we have a distinction in here with professional services. We establish fair market value as regional commercial average. So we'd be looking at data from claims that were previously paid in network amounts and taking a regional average of that across carriers to get a regional average amount.
Well, so are you telling me that if I don't have health insurance, don't have Medicaid, and I get a bill for my services, say it's a $5,000 bill, and Anthem, if I'd had it, or whatever my health care plan was, would have paid $3,000. You're telling me the $5,000 that I'm being billed by my local hospital is not fair market value?
I think the issue, Mr. Chairman, Senator Overchain, the issue here is
That'd be great.
No, I don't agree. The issue here is we're dealing with in-network and out-of-network. And the fundamental challenge we have is we're basing payment on in-network claims, in-network payment amounts. If the in-network amount were an agreed-to amount, were in a market amount, that provider would be in network and we wouldn't have that challenge. So this is dealing with an out-of-network claim for emergency services, which on the hospital side is expected to be very rare. We do know that these instances do occur in the professional side and the physician side, and we've established a regional commercial average for that. So all that we're doing is basically, as you've suggested, we're looking at the in-network payment amount, but we're applying a regional average for that. And by doing so, we get away from having the unintended consequences of allowing the payer to unilaterally determine the payment amount.
So, Mr. Chairman, and I don't mean to be unduly provocative, but when I get that $5,000 bill as an uninsured person, does that mean I can contest it and say you're not charging me fair market value?
Mr. Chairman, in this instance, the patient is held completely harmless. Today, you do have that situation. Today, under the law, you have a greater of 3 rule. The insurer has a minimum amount it must pay to live up to its end of the bargain. The law today allows you to expressly authorizes the provider to balance bill you. That is the law that is on the books today.
Yeah, I think we're saying we're
changing
each other,
that.
but that's okay.
Okay.
Thanks.
Let me ask this question. Would anybody have an objection as we said fair market value as approved by the State Corporation Commission? So we have a neutral set of eyes to look that over? Would there be an objection to that?
I would, Mr. Chairman.
You would object to having the SCC?
Yes, because the SCC, in my opinion, is like I call it the KGB. You can't ask them no question.
Well, I think there are a number of us that rely on the SCC to ensure that where we've granted monopolies, and some would say with a CON we have granted monopolies, but that we rely on them to ensure that the consumers are getting a fair and competitive rate and they're not being overcharged. So I understand that, but you got anything else there, Glenn?
That's generally the idea is, we're protecting the patients with this, Mr. Chairman. The other thing that we are doing is we're ensuring that they're covered for emergency services regardless of the ultimate diagnosis. So if somebody comes into the emergency room with chest pain, but they end up not having had a heart attack, but they have to get all the services.
I understand that part,
Okay.
but would you have any problem with allowing the SCC to review and sign off on fair market value? I'm not asking them to set it. I'm asking them to look at it to determine whether or not that would be fair market value.
You want to talk to that?
Sure. Mr. Chairman, members of the committee, Amy Perrin-Seibert. There's actually a review process already in the bill, so we already have the Bureau of Insurance who will, if there's a complaint either by the provider or by the insurer, they can go to the Bureau of Insurance and they can go and check and see if that is a fair market value, if that is being paid, as well as the regional commercial average for professionals. So that's actually already in the bill.
But one would assume the fair market values are kind of predetermined anyway. And you think the review is sufficient enough there?
I think the definition of fair market value is a worthy conversation, which I would love to have.
Well, you have to stop up here and let's have it, because that's the key to the bill.
Okay. So what's going on here is balance billing only happens in a teeny percentage of cases. We're talking 2%. The reason that it happens in those 2% is because the other 98% are in network. They're in network because we negotiated contracts and got them in network. What this formula does is basically set it up to pay the provider more than they get paid in network, which will encourage them to leave the network and demand a higher payment. If you look at the language of fair market value, it includes single case agreements, emergency-only patient agreements. What they're doing is including the spoils of balanced billing in the formula for what they get paid as an out-of-network provider after it's gone. Now, the whole point here is that we want to stop an outrageous balance bill of, let's say, 30 grand for a plastic surgery consult on a broken nose in an ER, like what happened in Northern Virginia. If you want to get rid of that, you ban balance billing. What this does is convert the issue into a way for the other 90%, 88% to get an increase in pay. And it creates two formulas. The other formula also includes case agreements, and it ties it to 2017. So it would include settlements that were settling a case that included the big balance bill to make it go away. That's not how you make a fair formula. That's how you make an unfair formula. This formula is written to include the spoils of balance billing in the formula. That doesn't make any sense. And what it will do is undermine the networks and increase rates across the board as people leave and demand more.
And I've listened to this debate now for 10 years between all the competing sides. And last year, as we moved through the budget and we went through Medicaid expansion, I remember significantly that we don't make enough on Medicaid. It only pays, I want to say, 74, 75% of our costs. So we moved that budget up to 83% of what we were told were the costs on the hospitals. And everybody said, okay, that's good. The hospital said we can live with that. And Medicare pays, I've been told by them, 88% of their costs. Now, remember, they determined their costs. So I took the strategy of, okay, if that's the route we're going, why don't we just set this thing at 140% of cost, which one would think would provide a significant profit margin for the nonprofit hospitals, a fixed rate like that where we set those costs based on a Medicare formula not to exceed the Medicare costs, which is the tack that my bill took. So, and maybe 40%, maybe it should be a little richer. I don't know. But I picked that number as the bill, and I think that's the base of the debate. I am tired, personally, of having to come back and hear these same arguments over and over and over again, and all I see on the results is people I represent paying more and more and more for the identical services. And that's the problem that I have, and that's the bill I have, Senator Sturdivant, that's different than yours, which is why I took the tack that I did. I think in the course of this, we have two distinct methods of going about it, and it really is up to the committee to decide, but I wanted to be aware of the nature of the bill that I took.
Mr. Chairman?
Yes.
So since it's different and not a compromise, then why can't we just hear both bills and vote on both bills up or down?
Yeah. All right. Well, then let's do that. Let me get the subject. What's the bill number? 1360. We're going to have put both of these bills up, which is not the normal way we proceed. I'm not quite sure how we do this, but is there a motion on the substitute for 1360? It's been moved and seconded. The substitute be adopted. All those in favor say aye.
Is this whose substitute you talking about now?
Okay. All right.
No.
I believe I've explained my substitute, Senator Spool. We cannot take up two bills in the same time.
Yes, sir.
You understand there's two different alternatives here. One's the one proposed by Senator Sturdivant.
Yes, sir.
And one's the one proposed by me that gets away from this and bases on what everybody in the healthcare industry told me was 83% of their cost, 87% of their costs. Therefore, I went, okay, if that's your cost, let's go 140% of Medicare, giving you a nice profit margin.
All I want to know is who we going to vote on first?
Okay, we're going to vote on, now that I think, does the committee understand where we're at in the posture we're in? Okay, we are on Senator Sturdivant's bill. You are aware that there's an alternative to Senator Sturdivant's bill. So is there a motion on Senator Sturdivant's bill?
Mr. Chairman, there are folks here who want to speak in favor of it, especially from the patient's perspective.
Absolutely. Let's hear from them.
Thank you.
Chairman and members of the committee, my name is, I'm here to speak for patients. My name is Donna Gwynn, and I'm here on behalf of the National Patient Advocate Foundation. We're the advocacy affiliate of Patient Advocate Foundation, representing voices of adults, children, and families coping with serious and chronic illnesses nationwide. We're headquartered in Hampton, Virginia. Patient Advocate Foundation provides direct case management, financial support, and educational services to tens of thousands of primarily low-income patients and caregivers each year. In 2018, Patient Advocate Foundation served over 142,000 patients across the country, including 27 specific cases in Virginia. Financial hardship resulting from medical costs, including surprise medical billing, continues to be the top, and I say top again, reasons patients and caregivers contact Patient Advocate Foundation for assistance. In 2017 alone, debt crisis was the second largest issue affecting patients seeking assistance from Patient Advocate Foundation. So we applaud the efforts this patron has taken to address the issue of balance billing or surprise out-of-network bills. We're all too familiar with the stories. A patient receives a surprise medical bill after unknowingly or involuntarily receiving medical care from a healthcare provider or facility that is out of network. This practice unfairly leaves patients stuck in the middle. National Patient Advocate Foundation supports this measure that will protect patients from balance billing. Patients should not be held financially responsible for balance billing due to unexpected out-of-network care in both emergency.
Excuse me. Yeah.
Just okay.
Just
so
wait,
let me just, the only thing I do want to add.
I'm going to pause because there's a question from one of the committee
yes,
members.
Sir.
Senator Obenshain.
You're stopping
yes,
your timer, so.
Yes, okay.
Quick question.
Yes, sir.
Do you have a preferences between?
I do, and the reason why is his bill basically covers 4 patient protections, and yours covers 1. So we're looking at something that's going to help patients. I do want to add, though, that
Mr. Chairman, you got 3 minutes. She's taking up all the time.
Okay.
Okay.
I apologize. Thank you very much for the opportunity to speak on behalf of patients.
All of the people that stayed or just
No, it's supposed to be 3 minutes for the entire side. So.
That's what I was thinking.
Okay.
And
all
I
right.
don't think they understood.
All right. Yes,
Hi,
sir.
my name is Bruce Lowe. I'm an emergency physician in Southeast Virginia. I'm also the president for Virginia College of Emergency Physicians. I won't rehash a lot of the discussion that you already have, but there is one small difference between the 2 bills, which is also about protecting patients. Behind me, there are med students from across the state that are also in support of Senator Silverman's bill. The payment for out-of-network would go directly to the provider and not to the patient, because that puts patients in the middle, and we want to take them completely out of the middle. In addressing the whole thing about in-network, I know you talked about the hospital, but from the provider side, let me tell you the one thing about providers that when you negotiate as a small group with insurance companies, everybody has a different in-network with an in-network rate. Some is good, some is not good. Usually what's off the shelf is not good. Usually it's insufficient. And the problem becomes it's opaque. You have no way to know what the in-network rate is. And by using a database like the VHI database for fair market value, it does allow for openness and transparency to happen. And so that's why we are very much in support of Senator Stewart's bill. Thank you.
Well, Doctor, my substitute does include direct payment, and I would say you can't get much more open and have a knowledgeable public than base it off a percentage of Medicare, because the Medicare public prices are published. But I'm sorry, I took up a little bit of time, so I'll give you some more. Okay. Are there others? Yes, ma'am.
Good afternoon, Mr. Chair and members of the committee. My name is Sally Matchett, and I live in Henrico. I'm in support of this bill because I am someone who has been affected by this balance billing. I'd never heard of balance billing until it had happened to me and my daughter in 2 different incidences. I was confused and actually angry. I reached out to the local media and had a news station that shared my story on television. I soon heard from hundreds of other patients who had similar experiences, and that's why I'm here today on behalf of patients like me asking you to support this bill. We need to ban balance billing, but we need to do it in a smart way that protects patients and make sure that people like me always have an emergency room with good doctors to go to when we need it. This bill does this, and that is why the doctors, hospitals, and patients like me support it.
I thank you very much. Okay.
Mr. Chairman, members of the committee, Jill Hankin from the Virginia Poverty Law Center. Thank you to all the patrons who have worked really hard to remove the consumer from this balance billing problem. That is a major step forward. There's more to be done, but that's a major step forward. So the debate is about how much the parties pay to, how much the plans pay to the providers. And I believe some kind of average is the way to go. We should have the Bureau involved in the discussion. And I think both Senator Sturtevant's bill and your bill, Senator Wagner, you're not talking, what I see in your substitute, which I just got, does not talk about Medicare rates, but it does talk about an average.
Mhm. I average to the average, but I'm
And,
willing to go back to Medicare rates.
I do think that it's important to set up a system where the plans have to pay certain providers something more based on averages, because otherwise they can undercut the market on their own. So at this juncture, I'm supporting Senator Sturtevant's bill. Thank you.
Okay.
Mr. Chairman, just one final thing, and this was pointed out, but I think it directly answers your question, that the state corporation shall resolve disputes. This is my bill. SCC shall resolve disputes between healthcare providers and health carriers regarding appropriate reimbursement amount. So there is some involvement of SCC and some independent mediation between.
Let me ask a question. Doug, you read my substitute, and you just had a chance, okay? I authorized a little bit of language on the fly without having an opportunity to see it, and I just got the substitute. So does my substitute cover some of your concerns?
Your substitute covers all of our concerns. It requires direct payment. It honors all of the requests of the ER docs and others on final diagnosis code and strengthening EMTALA. And it also basically modifies the existing statute to use an average of the plan's negotiated rates in the region, which is the appropriate way to go. When you average across multiple plans, what you end up doing is bumping the number up. And what they've included, there's a footnote from the data they used that basically said they equally weighted the plan regardless of the number of enrollees. So if you have 1 million enrollees with a low rate and you've got 10,000 with a high rate, they're averaging those two together as if it's 1 and 1. That is not the fair way to make an average. An average of the negotiated rate of the carrier in that region certainly would be a fair way to go, and the Bureau can collect that data.
Okay. All right. You all see the differences, and I apologize for focusing on the Medicare rate. I did agree to the language, and you'll see it on line 30, 31, and 32 of my substitute if you want to read it. We have two distinct methods of approach. We will now deal with Senator Sturtevant's bill, knowing that my bill will be dealt with next. Okay. So the motion, do I have a motion?
So moved. Move to report.
It's been moved and seconded that the bill be reported. Clerk, open the rolls.
Eleven ayes, 4 nays.
Okay.
Thank you, Mr. Chairman.
All right. And then we'll go ahead and take my bill up. Is there a motion to report? What's that? Why not?
Mr. Chairman?
Okay. Been moved and seconded that my bill be reported also.
Mr. Chairman, question. Doesn't the passage of Senator Sturtevant's bill make your bill moot?
I don't believe so. I think we could send both of them out, or we can have this fight on the floor with a substitute because it is germane. Or we can have two different vehicles and give the House 2 bites at the apple. This is not an amendment where it would be a moot point, but we are sending out two distinct different policies if we send my bill out. That's appropriate. Okay, it's been moved and seconded that 1360 be reported. Clerk, open the rolls.
Six ayes, 9 nays.
Okay, that bill fails to report. Yes. Senator
Chairman, with your permission, I think it would be right to roll your bills into the other bills so that both ideas are both on the table, especially as we start to head toward conference. Would you consider rolling your bill into the Sturtevant bill?
Sure, but it won't prevent me from putting the floor substitute out there, okay?
So moved, Mr. Chairman. I move that we roll the bills together.
All right. All right, been moved and seconded that we roll the two bills together. Clerk, open the rolls.
14 ayes, 0 nays.
Okay. All right, those two bills are rolled together. What's left? Not much time. Okay, is there a motion to strike Senator Marston's bill? Been moved and seconded. That do. Clerk, open the rolls. Senator McDougal, you have a bill? That bill is stricken.
Mr. Chairman, mine probably needs to be rolled into the one that went out because it had a lot of the same concepts.
Which bill? Disturbance?
Mr. Chairman, I think that's the only one left, so yes.
Okay, all right. It's been moved and seconded Senator
You limited
McDougal's
my
bill be
choices.
rolled into Senator Sturtevant's bill. Clerk, open the roll. That's 1354. All right, we have Senator Black, and I have one bill left. Would that be true, Mr. Chairman? Two bills. Okay. All right. Let me say this. We're going to have to rise. We will find a time to take up these bills. I know there's going to be people that want to weigh in. We'll figure out sometime this afternoon. Take a recess. We'll come back down here and we'll finish off the docket. And with that, the committee will rise.